We have achieved 1 million lens implants. We are star. And infinity is the next milestone. We have achieved 1 million lens implants. We are star. And infinity is the next milestone. We have achieved 1 million lens implants. We are star. And infinity is the next milestone. We have achieved 1 million lens implants. We are star. And infinity is the next milestone. We have achieved 1 million lens implants. We are star. And infinity is the next milestone. We have achieved 1 million lens implants. We are star. And infinity is the next milestone. We have achieved 1 million lens implants. We are star. Infinity is the next milestone.
Okay.
Yeah.
Can you just stop sharing that video? So good evening to all of you and good morning to people in the US, good afternoon to people in the UK, good night to people in the Southeast. And because we have people from all over the world, okay, can you stop sharing? Welcome again to this Pan-International Ophthalmic Webinar of IIRSI. I am Dr. Mohan Rajan. Along with me is the coordinator or moderator for this Hall D, Dr. Rohit Om Prakash from Amritsar. And we've got a fantastic, very interesting symposium lined up for you for the next half an hour. And we have an expert panel, Dr. Arulmozhi Varman, Dr. J.K. Reddy, and myself here, and very good speakers as well. And each speaker is going to have 4 minutes time. Before I start the program, I would like to congratulate Amar and his team for the wonderful thing, because we had more than 9,500 registrations from across the world for this. It's a record registration for more than 130 countries, which is a record by itself. And more importantly, I also want to congratulate Appasamy Associates. Appasamy Associates is the guys who have taken Indian ophthalmology to the international level, bringing availability and accessibility of each and every quality eye care products. And hats off to Appasamy people. And it's only appropriate that we inaugurate the entire IIRSI Hall D Symposium with the Appasamy Symposium as well. And over to Dr. Arulmozhi Varman for his introduction of the speakers, and then we go on.
Thank you, Mohan. Let me welcome the audience to this wonderful symposium. We have a fantastic faculty here and very, very interesting topics that lead us from the latest in IOLs to cataract to refractive to pediatric ophthalmology. Every speaker gets 4 minutes, so I request the speakers to stick to the time if possible. We'll keep the introductions really brief and we'll take it from there. Our first speaker is a very well-known speaker, Dr. Rajesh Sinha, who's a professor of ophthalmology at the AIMS, New Delhi. His interests lie in refractive cataract and LASIK surgeries and corneal refractive surgeries. So he's going to talk to us about the novel EDOF IOL designs, which is the new kid on the block. And we like to know how this is going to pan off and how we're going to get good results from this. Let me, without any further delay, ask Dr. Rajesh to come online.
Thank you, Dr. Arul, and I would like to thank Team IIRSI. I would like to thank Team IIRSI and Dr. Amar in particular and Appasamy for having me in this webinar. I'll be talking about my experience of Supraphob Infocus IOL, which is an extended range of vision IOL. The intraocular lens started to be implanted in 1949 by Harold Ridley, and since then it has evolved so much that a lot of things have to be learned in order to understand the real physics of intraocular lens. The basic target initially was to have a 6x6 vision by putting the IOL 6x6 uncorrected. But then things started changing as we tried to achieve, and as we achieved 6x6 vision, people started to think of spectacle independence, started to think of uncorrected N6 vision also, and that is how multifocal lenses came. And then came the time when people are more and more working on the laptops and the computers, and then the issue of intermediate vision came into being, and that is how the concept of extended range of vision came. The Supraphob Infocus IOL is a unique design. It has that ability to extend the depth of focus and provide greater range of use and visual acuity. It has a central zone of 1.2 millimeters diameter, which has a nano diffractive optics primarily for near and intermediate vision with add of 3.5 diopter to focus the objects at 33 centimeter to 80 centimeter. And then you have an edge which is directed inwards. So the light which falls on the edge, it bends inward, and it eliminates scattering of light and eliminates glare. And then from 1.21 millimeter to 4.75 millimeter, the refractive spherical part of the IOL is designed to focus rays from distant objects, providing distance vision. Now, we included 55 patients, 110 eyes, out of which 52 patients and 104 eyes, we have complete data, and we evaluated. 6 months follow-up was done. This is how the procedure was done. A temporal clear corneal incision was made, 2.2 millimeters, and then the cataract surgery was performed. Once the nuclear emulsification and cortical aspiration was done, the incision was enlarged to 2.8 millimeters. And then the intraocular lens was implanted through this 2.8 millimeter incision into the bag. And then the viscoelastic was aspirated out from above and behind the lens. And this is the end of it. So the average age of the patient was 58 years. We had 27 males and 25 females. And the post-op visual acuity at 3 months uncorrected was log mark 0.11. Which is again close to 6.6, and corrected distance visual acuity was 0.02, which is almost 6.6. The intermediate visual acuity was at 3 months uncorrected was 0.15, and corrected distance intermediate visual acuity was, when distance was corrected, then the intermediate visual acuity was 0.09. You can see at 3 months time, 63 eyes had near vision of, okay. The 63 eyes had near vision of N6, 34 had a near vision of N8, and 7 had more than that. And after distance correction, 103 eyes had near vision of N6. The spectacle independence was seen in 96% for distance and 92% for near. Contrast sensitivity was close to normal. The distance stereo acuity was also close to an acceptable range, along with the higher order aberration. This was a defocus curve that was shown. And as I mentioned earlier, good stereopsis, distance and near, as well as spectacle independence. This is the article that was published based on the study just recently in Indian Journal of Ophthalmology. So in conclusion, the Supraphob Infocus lens provides a good distance, intermediate and near acuity with this new design, hybrid optic IOL. It provides a good contrast sensitivity, good distance and near stereo acuity also, which is close to normal, no significant photic phenomenon, acceptable level of aberrations with 3 to 5 millimeter pupil size, and all the patients had good satisfaction and spectacle independence. Thank you very much for your patient listening.
Yeah. Arul, next speaker.
One just had a comment on this lens. It's a fantastic lens with very good results, and we look forward to more people using this. So let's have Dr. Rojesh Saxena, again a professor of ophthalmology from AIMS, whose his interest lies with pediatric ophthalmology. He's going to talk to us about prevention and control of myopia in children. Dr. Rohit, you can come on.
Sorry. Thank you very much, IIRSI team, Amar, and everybody involved with the organization for giving me the opportunity to be here, and Appaswamy to this program, as well as the lens and as well as the drug I'm going to talk about. So I'm going to talk about prevention and control of myopia. And we all know from this paper that probably by 2050, 50% of the world's population is going to be myopic. Now, while it may be interesting and an opportunity for some refractive surgeons, I can see, but it is a major problem when we look at our children who are going to be myopic, and close to 50% of them are going to be wearing glasses, which is most unfortunate, along with the myopic complications they're going to have. While it has not been such a concern in India, and our study had found about 13% prevalence, but we realized that it is up from 7% to 13% in just little over a decade, and a cumulative incidence of 3.3%, which is very significant. So we realize that in another decade, the prevalence will be up to 30%. So we prevent onset by identifying the pre-myopic child, which is a low hyperopic with respect to age, where one or both parents are myopic, spend less time outdoors, have increased near activity, which is the most unfortunate effect of this pandemic, and have, of course, some binocular vision disorders. So you manage that by increasing awareness among parents, risk factor modulation, as well as outdoor activity. Preventing progression, we have a lot of optical interventions, and the only real proven one is atropine 0.01%. Single vision spectacles, contact lenses, peripheral ads, spectacles have been shown to have no impact on the progression of myopia. Only soft multifocal contact lenses, in fact, the first FDA-approved intervention for myopia is this Cooper Vision Me Sight contact lenses. And orthokeratology are the optical interventions that have shown some impact to the progression of myopia. Pharmacologically, a lot of drugs were tried, but low-dose atropine, 0.01%, has consistently across studies and across nations has shown that it has a role in preventing progression of myopia in children, and now is available in India and in certain countries, although still not FDA approved, for the use of preventing progression of myopia. It was the Indian Atropine for Prevention of Myopia study, thankfully very grateful to Appaswamy, their product Myopin, that was used in randomized double-blind clinical trial, which involved 3 centers, Shankar Nethralaya, Narayan Nethralaya, and RP Center. And we enrolled 100 children randomized to placebo versus atropine, and with a mean age of 10 years, and 92% completed the follow-up. We found no significant side effects that required discontinuation, neither significant near vision or accommodation. These are the results which showed a significant reduction in the progression or change in spherical equivalent in the atropine group as compared to placebo, and nothing else was significantly different. And this is the curve you can see that over a 12-month follow-up period, a significant reduction in the refractive error occurred. And atropine, therefore, has a very significant role in effective and efficient reduction in progression of myopia. So we are at reducing myopia by increasing awareness, increasing outdoor activity, as well as atropine drops. Therefore, try to keep children to go out, and to prevent progression, role of atropine, low-dose atropine is a must. Thank you.
Thank you, Dr. Saxena. You did fantastic. You were just exactly in time. Thank you so much. And yes, your paper was fantastic, very useful study. Let's look forward to more of us using the
I just want to make one comment, Arul. Yeah. So as he rightly said, it's a multifactorial. So many other factors we have to take into account apart from atropine, like outdoor activity and exposure to sunlight and other things, and probably gadget usage. So many other factors come into use. So all these things, I think they're doing a study now combining everything. We'll know the results after 6 months or 1 year. But it's a very good paper. Go to the next speaker.
Thank you, Mohan. The next speaker is from Mumbai, a well-known and prolific surgeon, both in cataract, refractive, and retina. Is Dr. Ashwin Bafna. He's going to talk to us about robotic laser, the new game changer.
Thank you, IIRSI and Appaswamy Associates for this opportunity. What I'm going to do is probably introduce a new machine, but I think it's a game changer, not for the company, but for the ophthalmologist as such. That's why I'm presenting this. Even though I'm currently a user of this machine, but I don't have any financial interest, but it's always welcome from Appaswamy Associates. So basically, all of us who want to start a LASIK practice, we always think about the investments and returns, the high maintenance of the machine. Some of us in big cities have space constraint, whether we'll be able to make it affordable to the patient in this hour of competition. It requires a lot of skill, is the enigma that all of us face. We do not have too much of knowledge about everything. And all of us want spot-on performance in LASIK, because that is the ultimate outcome that we all want. So basically, what is robotic LASIK? It's a normal argon fluoride gas excimer laser. Robotic because in this laser, the arm which delivers the laser moves, unlike the conventional machine where the bed moves. So on the left is the conventional laser, and on the right is the robotic laser. So it is a 600 hertz machine. It has an eye tracker which is pupil dependent. The spot size is around 0.5 millimeters. And these are the various treatment strategies available when you have a transepithelial PRK. you have presbyopic correction, you have topolink, which can now be assimilated with sclerotomy or pentacam topography. So basically, if you
Bafna, you're gone.
laser delivery apparatus and the plume extractor. What I mean is, now you'll see in this video. So here I'm creating a flap. Now, am I audible?
Not very clear, Bafna.
Hello?
Comes and goes.
Yeah, it comes and goes. Yeah. Please go ahead.
Now it's okay?
Yeah, it's better.
Let's start from where yeah.
It's again hanging.
Yeah. Just 1 minute more for you, Bafna, but can you come back again after some, maybe we can finish off the next speaker?
So now it's okay?
Yeah, now it's okay.
Yeah.
Audio is okay, but we're not able to see your video.
Now you're able to see the video?
No.
We only can see you.
You'll have to share the screen. It's not shared.
We'll do one thing, Bafna. You come back
Okay.
after the next speaker.
No, he's come back. He's come back now.
Okay.
Okay.
Yes, go on, Bafna. Please do.
Yes. So there we have made the flap and retracted it behind. And then what you will see here is the robotic arm. It's controlled by the screen. When you say move to the eye, it just moves on top of the eye. Now it's okay?
Yeah, it's okay.
Yeah, it's fine.
Yeah, fine. So you see the apparatus. Now that is the eye stabilizing apparatus that is there, which will go and fix it onto the sclera. So it goes very close to the eye. If you see the red dot here, when it goes down, it becomes green. That is the time when the eye is applanated by the four prongs. Now you can see the eye getting applanated there. And on the screen, that red dot has become green. The eye constantly maintains fixation through the hole has to be in the small green circle there. And that's when you start your laser delivery. So when you have this apparatus on the eye actually cannot move during photo ablation. So it cannot move at all because it has been held tightly in that position by those four prongs. So it gives stability. So you'll never have that squeezing movement where the eyeball goes up. And then after your laser is away, the laser apparatus moves out and the microscope is again into the focus. So basically, it's a very compact machine. It can come into a 200 square feet room. And the entire laser apparatus here is below the bed, unlike other machines. Therefore, it's compact. And when the entire thing on top is open, the patient does not feel any kind of claustrophobia when you're
30 seconds more.
Yes, sir. So what is the major difference? The major difference is that the laser delivery apparatus is very close to the eye. Therefore, the influence of pH, temperature, etc. is very less. So this is what is called as the ultimate attachment, which you have seen. These are my results of 210 eyes in patients where I have done around 125 trans-PRK, 85 LASIK. 95% of them have achieved targets. And surprisingly, my TEPI-PRK patients have 612, 6.9 vision even on day one. So basically, I'll put everything in black and white. A cylinder in this in conventional machine costs you 5 lakhs or more in 1 year, which lasts for 1 year. In our year, it costs you half the price. No refills variation. There are 20 refills in this cylinder. Refill is required 1 or 2 times a week in the conventional machine. However, each refill in this machine lasts for around 40 static or dynamic 100 eyes. So you operate 2 times in a week in a conventional machine. Here you operate 24/7, 365 days. There is a CMC on conventional machine of around 20 to 25 lakhs rupees. Here there is no CMC till now.
Wind up,
the optic replacement in a conventional machine costs you 1 to 5 lakhs. Sir, almost over.
Yeah.
I think he's again gone offline.
Yeah.
About. And they have already 14, 15 installation all over the country. And very soon they'll be ready with their femto link. Thank you.
Thank you, Bafna. That was very nice. Actually, it's an eye-opener that this machine, the fixation of the eye is really interesting, and probably that will make a lot of difference. And of course, when it comes closer to the eye, even the cosine effect is kind of negated. Very interesting. We really should more installations of these.
Dr. Arul,
Yes, JK.
Yeah.
We are developing another arm for the same machine for slit lamp trans-PRK delivery, something like patient sitting position, trans-PRK delivery system. Introduced in next Singapore conference. Hope you also register. Come and see us.
Very good. Very good. Nice. Slit lamp delivery, is it? Very nice.
Not slit lamp. There won't be slit lamp. Sitting position delivery.
Yeah.
Another arm on the next side. It will go for sitting position.
Fantastic.
Beautiful.
Thank you, JK. So let's have the next speaker, Sudeep Das, who doesn't need any introduction, a well-known figure in Indian ophthalmology, the medical director of the Sankaraya Hospital in Orissa. Sudeep is going to talk to us about the refractive outcomes and safety profiles of the RIL, that is the Appasamy made Phakic IOLs. Sudeep, you're on.
Sudeep,
I think you have to unmute yourself.
No. Sudeep?
Okay, now it's okay?
Yes. Yeah, fine.
Yeah, thank you, Arul, for the introduction. Thank you, Appasamy and IIRSI for this opportunity. So I'll just go straight away with my... So this is what the RIL looks like for people who haven't used it. There are these 4 holes which are just outside the optical area, and because of this you don't really need a PI. I had done it in the first few, but then I've stopped recently. Not recently, actually quite a long time back. So it's made with a hydrophilic acrylic material, like all the phakic lenses. It's got 26% water. And it comes, the best part is it comes to the 0.25 millimeter step. So you can get right from 11.5 millimeters to 13.25. And because of the very small step, you can very accurately size it to the actual eye. And the optic size varies from 4.5 to 5 millimeter. And like I showed you those 4 holes, they call it the plate model with free fluid flow design, FFF design. And you can correct right from -1 diopter to -23 diopters. So you have an option of even the lower myopias not going in for a LASIK. And I've actually had pretty good results here for a smaller, lower paying place like this. It makes sense because you don't spend on the LASIK machine. And the other thing is that, of course, the high order aberrations are almost negligible in this, unlike a LASIK. And the one prerequisite is that there should be a stable refraction for at least 1 year. This is for all refractive surgeries. And this is ideal for patients who are not suitable for LASIK. Of course, you have to have at least a 2.8 millimeter aqueous depth, that's from the back of the cornea to the front of the lens, to be able to implant this. So this is, actually I've done a lot more. I've done 70 plus, but this is the probably 80 now. But these are the people I have at least 1 year data. So there were 28 bilateral, 7 unilateral, 63 eyes of 35 patients. 42 of them were toric RILs, and half of that, 21 were spherical RILs. The age varied from about 19 to 26, 46 male, 17 female. And we corrected right from -3.5 diopters to -20 diopters. And the astigmatic error varied from -1.5 to -4.5. And this is the schedule that we had. And like I said, almost all of them have been followed up for 1 year, some of them for 2 years also. We do refraction multiple times to avoid error, and I actually get it rechecked by my pediatric ophthalmologist because she is fabulous at refraction. And it's not easy at all when you're doing it in these high myopes. And all the measurements were done on actually the lens optical biometer, and I do the keratometry, the aqueous depth, lens thickness, axial length, and white to white also. But I do check the white to white with digital calipers, and if there is a significant difference, I actually stick with the value given in the digital calipers. I get an indirect my retina surgeon to check all these people to see if there is any people with breaks and all that, and we try to exclude these people. Even if they have a barrage, we try to exclude these people from that.
1 minute.
And, this was my data. So the mean correction was the refractive error was about -12, varied from cylinder was about -2. The uncorrected was 1.4, but after the surgery, it went to 0.2. So the average uncorrected distance vision was 260, it went to 6.9. And the best corrected vision, of course, was not bad, but with thick glasses from 6.9 to about 6.6. And the specular did not really change much. It was only about 1.4% reduction, and it remained steady after the 1 month. The other interesting thing was the average RIL vault was 647. We had some outliers. This was a time when our lens star, actually initially was depending purely on the lens star, and then our machine had broken down. They had sent a demo machine which didn't give an accurate white to white, and then we switched to digital caliper. So these high RL vault was at that time. So this is the most important thing. I mean, people mostly come without wearing glasses, and it's a phenomenal improvement. So we had 2 patients who had Uretz-Zavalia syndrome, that is a persistently dilated pupil, and both of them had it only in one eye. Yes, almost done. And this has been reported in other Phakic IOLs as well. The 2 cases of transient postoperative uveitis and no cases of glaucoma or lens opacities. So 96% of the RILs with a within 1 diopter of postoperative refractive error, and the IRL vault remained stable throughout the study period. There was no incidence of cataract at all. And the rotational stability in the toric RILs was excellent. And there was only a 1.24% loss of endothelial cells. And the satisfaction, of course, was extremely high. And this is a great option for treating moderate to high myopia. Thank you.
Thank you, Sudeep.
Very good.
In India, all of us use Appasami's RILs with fantastic results. They have a good range also, which is more than what you get from the international brands. So thank you so much for bringing it out. Now we have the last speaker for the session, a young ophthalmologist, dynamic ophthalmologist from Chennai, Dr. Kumaran Murugesan, who has a multi-specialty, super specialty eye hospital in Chennai. He's going to talk to us about optimizing fluidics for efficient cataract surgery. You're on, Kumaran.
Kumaran.
Good evening, all. A warm welcome to all. And at the outset, I'd like to thank Appasami and Dr. Agarwal for this opportunity. Because short of time, I'm going to go into my topic. And my topic of the day is optimizing fluidics for efficient cataract surgery. So all of us know that the most important factor in a safe cataract surgery is the control of the fluidics. So fluidics in other way can be defined as the amount of fluid coming and going inside the eye. There are multiple factors which determine the fluidics, and the most important one is being the size of the phaco needle tip. We all know that different surgeons use different techniques of phacoemulsification and use different bore size. Hence, the latest generation phacoemulsification machine has to be really versatile to accommodate all these parameters. And a one-step shop to answer all these versatility is the Galaxy Leo Orbit from the Appasami, which is an aesthetically designed a machine which has incorporated the active fluidics or the real-time fluidic system into this place. So the highlight of this machine is that the real-time fluidics, which has a controlled infusion into the anterior chamber based on the pressure changes inside. And additionally, it also has got a traditional gravity-based irrigation system, which some surgeons who are already used to it can use it. So the custom IP settings or the real-time fluidics can be set somewhere from 50 to 100 based on your phacoemulsifying techniques and the type of cataract. But I normally use the automated one where you forget about the settings and the machine, you allow the machine to take care of all the settings inside. And it also has a dematic cutter which goes up to 2000 cuts per second. One added feature about the handpiece is that it's a crystal handpiece which weighs only 23 grams, and it has a multi-directional or the orbital mode of the tip. So this lightweight handpiece helps the surgeon to perform all intraoperative maneuvers with ease. The other additional features are the inbuilt UPS system and the inbuilt compressor will be very helpful during anterior vitrectomy. And more important is the HD definition recording of all the surgeries. Okay, so this video demonstrates the main key features of the Galaxy Leo orbital system. First, the efficient fluidic technology is demonstrated by the stable anterior chamber, which also results in almost nil occlusion as shown here. This feature allows the surgeon to concentrate on all the nucleus disassembly maneuvers and not worry about the trampoline effect of the posterior capsule or a damage to the corneal endothelium, especially while operating on harder cataracts. And you'll be surprised to see that even with this system, the postoperative cornea on day one is very clear. Second, there is an efficient use of the balanced salt solution in this fluidic system, which is actually 20% less than the gravity-based system. This machine has got a special low fluid warning system where the machine shuts down the aspiration and the phaco power and just allows the irrigation to go through, which is very safe and which does not allow the chamber to collapse. And the surgeon can then change the BSS as when needed. Finally, the cumulative power used to emulsify a denser cataract as shown here is actually much less than 30%. This results in a postoperative clear cornea on day one. So each detail from greater anterior chamber stability, low temperature rise due to a reduced power output, and the efficient use of the balanced salt solution leads to an improved surgical outcome and makes the moment of your cataract procedure always better. So the upcoming video is on a soft cataract. Here also you'll see that the chamber is actually very stable, and you'll see all the nucleus coming towards the phaco tip because of the effective real-time active fluidics and the fluidic stability.
Can you make it fast?
Yes, sir. So, finally, the Galaxy Leo Orbit phacoemulsifying system is a state-of-art technology in par with any phacoemulsifying systems. Thank you.
Thank you, Dr. Kumar. That's fantastic. I personally use this machine and I vouch for it. I've taken it head-on a comparison with the Centurion, and it performs brilliantly. The active fluidics in this truly works flawlessly and gives you fabulous control over the maneuvers during phaco. Thank you so much.
Yeah.
Dr. Rohit, I hand it back to you.
Yeah, I think we come to the end of this fabulous session wherein we had the best of the speakers. So we now move on to the next set of speakers. If we can just log out and let the others join in. Yeah.
Thanks with all the speakers.
So now with this, with the first session on Appaswamy Symposium finishing, we have now to move on to the next one. Appaswamy has been the benchmark for Indian machines, Indian instruments, and Indian lasers. So they have come up a long way, and there is no second thought about it. Their machines have been such a revolution that it has been a great, use for ophthalmologists who happen to be in the initial and even in the advanced stage of their, practical application in cataract surgery and in refractive surgery. So we move on now to the star surgical ones, which would be, have the second session people locked in? Hello, the star surgical, Dr. Vartman is there, Dr. Parimal Desai, Dr. Hema Malini, Dr.
Yeah. Yes.
So are you all there?
Yeah, yes. Yes, yes.
Yeah. So I take this.
Yeah. Hi, Vartman, how are you?
Yeah.
Hi, sir, how are you? Everything is fine, how are you?
I think we should get it going because we are on now. So I request Dr. Parimal Desai to take over and get the ball rolling for this amazing session of Star Surgical on their, special things which they are coming up. We have a galaxy of speakers which Dr. Parimal Desai would be, introducing. Over to Dr. Parimal, please. Dr. Parimal.
Good evening, my dear friends.
Sir,
can you
add for 15 seconds?
Can you hear me?
Yeah.
Yes, yes.
Hello. Can you hear me, sir?
Yes, sir.
Hello. Can you listen to me?
Yeah, we can. Yeah. Your
Hello.
video is also there.
Sir Parimal Desai, you can start.
Video.
Hello. Hello.
But it has to start the session 5 minutes late already.
Hello.
Who's the first speaker? You can start,
Should we start with the first speaker?
Yes, ready.
Hello.
Here. Dr. Anant is ready.
Hello. Good evening. Hello.
Hello.
So,
Anant. Hello.
I'm
Can
ready.
you hear me?
Yeah, I can hear you.
I take this
We are ready.
opportunity. I think there is some problem with the audio. I take this opportunity to start with the first talk, which would be by Dr. Ananta D. The topic will be effective patient consulting in the new normal. Over to Dr. Ananta, please. Can you share your screen?
Yeah.
Doctor, you are going to share your screen or shall I share?
Yes. Yeah, you can share.
Yeah.
You're sharing it, Kannan? Yeah.
Hello.
Hello.
Is there any problem in starting? Can we, in the meantime, can we?
It has been shared, Doctor.
No, it's not there. Yeah, it's been shared, but the PPT has not started as of now. In the meantime, can we ask Dr. Vardman to start with his?
Yes, sure. Okay.
Yeah, I think it has been shared now.
Yeah.
Can I control it, Kannan, or you control? Hello, good evening, everyone. Is it audible?
Yeah.
Hello, good evening. Is it audible?
Yeah.
Yes.
What's going on?
Yes, go ahead, please.
Yeah, can you change the slide, Kannan?
Yeah.
Do I have an option to change? Yeah.
Change it.
So thank you, IIRSI and STAR for giving this opportunity. I'm just happy with Collamer, no financial disclosures. The reason why this STAR people might have given this consulting topic to me, maybe because I've done a huge number of ICLs even during this COVID crisis. Next slide, please. Next slide, please. So this terminology of new normal for a medical fraternity is new during this COVID-19 pandemic, but this was used by non-health sectors way back in 2007-8 when there was a financial crisis and during a global recession around 2010. Next slide. So this is how we would meet in 2018 and 19 at ITC Chola to discuss about the clinical aspects of ICL. Next slide. But this year, the theme of this STAR Surgical has changed and my topic also is slightly different. So I'll be just talking about the new consulting. Next slide, Kannan. Kannan, next slide. Yeah, this is how all our OPDs would appear before COVID-19. Next slide. And this is the new normal where patients, even if they come in families also, they are sitting separately with a mask, not able to talk to each other, to discuss to each other. This is what I miss. Word-to-word transmission within the hospital is not happening. Next slide. So when this new normal started, our practice started in such a way that all the patients who had really got their refractive workup done, they started calling up to the counselors and to the doctors. We also started up calling up all the patients who had refractive errors, who had previous checkup with us.
And I could see that more amount of people were opting for refractive surgeries, and the volume in refractive surgery was very high when compared to other subspecialty of ophthalmology. Next slide. The reason behind having more number of refractive surgeries, what I felt is majority of the IT employees were working more since they're working from home, and they were able to take 4 to 5 days of continuous leave. So they had much more free time, and they felt this is the best time to come to us. And colleges have not yet started, so they felt post-operative care will be better. They stay at home. And young housewife who had denied surgeries just because they didn't have any social help during those previous days, they felt that this is the ideal time they can take the leave. And the majority of the people who were seeking glass free from the entertainment industry, they would move around very busily. But now, since they're very free enough, more and more number of industry people approached us for refractive surgeries. Next slide. And we all know that refractive surgeons do become busy during marriage time. Majority of the marriage got postponed to October onwards. So refractive surgery has become a part of pre-wedding. Next slide. And this is one new problem which I noticed. All the glass wearers are continuously on the mask whenever they're active, and fogging became an issue. So this literally made this glass users a desperate situation, and this was the reason why majority of the people approached us for refractive procedures. Next slide. Next slide. Next slide, Kannan. And these young patients, they are aware that the young age group is at low risk of developing the COVID illness. So they didn't have fear, unlike the elderly patient, to visit to the hospitals. Next slide. Next slide. Previous one. And once these patients comes to the hospital, we always follow this technique. The SMS means sanitization, mask, and the social distancing. And the new normal from hospital side is telecounseling has taken up a big part. Whatever the doubts from the queries will be answered over the telephone. And from our social media is very active. We keep advertising on Facebook, WhatsApp, and on website also. And a lot of informative material regarding the refractive procedures were given on YouTube and FM radios. Next slide. Next slide.
I think the given time is over, you know. You already crossed more than 4 minutes.
Sir, sorry, but I think this...
Your time is over. Yeah. Could you
just... your time is over now.
Yes, sir.
Can you wind it up, please?
Yeah.
Okay. Next speaker is Vardhan, the young dynamic person. He is the director of Asian Eye Hospital, Pune. He has experience of more than 25,000 refractive surgery. He is in his area of... Okay. Now, please, Anant, Vardhan, you can just take up the mic.
Yeah, thank you, sir. I will just share my presentation. Just a second.
चार मिनट एग्जैक्ट स्टार्ट आज no
okay start
yeah that's one there's some just give me a second yes
nothing.
Just anything, I'll start. I think, thank you so much, sir. I think there is some issue with the presentation, but I'm going to start just from this slide. So I'm going to talk to all of you about the surgical aspects of the ICL procedure. We all know that ICL is one of the most important procedures when it comes to the armamentary and refractive surgery. And we typically choose ICLs for patients who are actually LASIK rejects or who are having very high ametropia, more than -8 diopters of myopia, plus 5 diopters, and more than -4 diopters of astigmatism. Is my presentation seen?
Yeah, but the video is not.
Yes.
It's visible. It's visible.
Yeah.
But your video is not working.
Once. I cannot see my cursor also. I think there's some issue with this. Wow. Can somebody from the admin side stop sharing my presentation? Because when I go to the escape key also, it is not working. Somebody from the technical side?
Would you like Sonu to talk and then you
Okay, sir. Yes, sir.
start again?
Yes, sir.
Sonu, are you on the line?
Yeah, I'm on the line, sir. I can start.
You can please start. Yeah.
Can you just log out? Vardman, can you stop sharing the screen?
Yeah. I think, no, the thing is that my screen has actually gone blank.
Okay.
What
So
I will
what
do
you
is,
can do is you can,
my laptop, I think.
you can relog in to the Zoom. You can sign out from the Zoom and relog in.
Kindly leave the meeting so that will make it, and you can log back.
I will switch off my.
Good job taking a meeting.
Is my slide visible?
No, I think
no.
Vardman's there.
It's not there?
Dr. Vardman's is there, not yours.
Enter the Evo zone, sir.
No, not at all.
I think everybody should log out and log in again. That is how this will resume.
Still not sharing, sir?
No.
No.
Okay. So I think Vardman, yours. Yeah. I think
now share it, please.
Okay.
Yes, now correct.
No, it's
Please, Sonu, please start.
So is it okay now?
Yeah.
So a very good evening and thanks IIRSI, Dr. Ramar Agarwal, Ashwin for making me a part of this wonderful event. I think nothing can replace the live and the virtual at the Chola. But yes, this is the way how it should be. Enter the Evo zone. So I've been asked to talk about the Evo Plus Vision ICL. So the Evo Plus is based on the current Vision ICL with a single port, that is the V4C. The Evo Plus Vision ICL is basically designed to with an increased optic diameter with an expanded diameter range, 5 millimeter to 6.1 millimeter, in spherical powers of basically -0.5 to -14 diopters. So this enlarged optic zone is what is the Evo Plus, we call it. So if you see here on the top is the Evo Plus from -0.5 to -14, and any power beyond -14. So the V4C is now labeled as the Evo, so -14.5 to -18. The basic advantage, the Evo Plus ICL has an expanded optic diameter, the optimal quality, and basically is developed for patients with larger pupils. So we have this millennial population with us, the younger population with larger pupils and the night driving. So it is basically addressed these larger pupil population. The refractive correction with the larger optic zones is basically beneficial because the transition zone, which can at times cause decreased the visual quality, and it can increase the incidences of glares, halos, and higher order aberrations. So it is very well addressed when you have a larger optic zone with the Evo Plus ICL. This wonderful article in the JCRS compared the optical quality in vitro of the Evo Vision ICL V4C and the Evo Plus at 4 different spherical powers and optical apertures of 3, 4.5 and 4.5. The Evo Plus Vision lenses were also assessed at the largest optical aperture of 6 millimeters. So the RMS, or the root value of the higher order aberrations up to the 7th order, trefoil, coma, tetrafoil, and the secondary astigmatism showed no statistical significance between the models for any power and optic aperture. So that means patients with larger optical diameters could benefit from this Evo Plus Vision ICL. So this is a wonderful paper which established, if you see in younger population between 21 to 45 years of age, the average pupil diameter in the night driving range is between 5.4 plus minus 0.7. So on the higher end, it can go as high as 6.1 or 6.2. So me being, and we all being as refractive surgeons doing femto LASIK or SMILE, addressing larger optic zones on the cornea, basically means burning more of cornea, taking more of depth. So actually, this ICL with the Evo Plus with a larger optic zone is what addresses this problem. So if you see here, the spherical lenses between minus 0.5 to minus 9. The current optical diameter is 5.8, but with the Evo Plus, it goes as high as 1. And the optical zone at the corneal plane is 7.6. So that means this at the corneal plane can never be addressed by using any platform or any cornea-based surgeries. So this is where this Evo Plus has an edge. And similarly with the toric platform with minus 0.5 to minus 14, their optic diameter goes as high as 6.1. So that means it translates at the corneal level to almost 7.6. So somewhere between 6.6 to 7.6. So this is one of the patient who came to us, a 20-year-old gentleman, Phakic 520, the pupil 6.2. He was basically an active sports cyclist, and he was very fond of night driving and motorcycling.
Your time is over. So your time is over.
Just the last slide, sir. So the error was minus 9.5 to 1.5, and this could never be addressed using a femto LASIK or a SMILE platform, and neither by the V4C. So only Evo Plus is the answer for this patient. So I think Evo Plus is a great platform when we are taking patients with refractive errors where you have larger pupils. And I always offer my patients, even for low diopters, these ICL lenses, because regression though can be an issue, glare yellows can be an issue when you have smaller optic zones. Thank you very much.
Our next speaker is Dr. Jeevan Tatyal, the director of RP Center and my great friend. He will just talk on lens-based refractive surgery is here to stay. Dr. Jeevan.
Yes, thank you. Can you see my setup?
Yes.
Can you hear me? Where do I meet?
Yes.
Can you hear me?
Please start. Yes, we can hear you.
Okay, thank you. Thank you very much for this opportunity, especially the Star India people. Let me talk something what Sonu has talked about in this Phakic IOLs. Thanks to my institution, which gives me opportunity to speak in such a beautiful conference. Phakic IOL does have advantage of being a procedure of choice for a moderate to high myopia in terms of hypermetropia, also with superior efficacy, safety, predictability, and most importantly, the potential reversibility of this procedure. This is a wide range of power correction available from a Star or Indian lenses, which we just heard in the previous session, IPCL or Acryl or Upper Swami lenses. They give it 0.5 diopters to almost 30 diopters and gives you a range of a customization now with the Indian designs. And now with IPCL giving you a presbyopic range also is a wonderful way to look into. The various designs which have come in the ICL does improve the its outcomes with the newer generation lenses, more safer, less complications. As far as surgery concerned, it's become very safe, effective, especially with a minimal manipulation using a 1% shoulder halonate, which gives a nice adequate cushion during the implantation and during the manipulation inside the anterior chamber, and prevents the fluid flow directly impacting onto the anterior lens capsule. And over that, I think we know that proper sizing is so important nowadays. White to white is still is a standard way to look into. Sulcus to sulcus are some problems. But now we look into another dimension of angle to angle distance by having a high definition OCT, which can give you a 360-degree assessment of entire cornea as well as angle structure, which gives you angle opening distance, and the trabecular iris angle, which gives you a guideline for assessing these cases pre and post-op so that you can do better job. Surgical technique, Sonu talked about. IOCT does give you an assessment on the table, how much bald is there. Sometimes you can have an excessive bald or a very flat bald. You can exchange the lens at that time itself. The surgery is very, very simple. It is effective. And the learning curve is hardly any there for a cataract surgeons. So this is sodium hyaluronate. You can see the cords of sodium hyaluronate, which gives you a nice cushion between the lens and the crystalline lens anterior capsule. There's no direct impact on the anterior lens capsule with the viscoelastic. Beautiful maintenance of anterior chamber you can see here. And subsequently, you can place the lens. Toric lenses, if you have image guided system, which will give you a better assessment. Removal of viscoelastic is very simple with sodium hyaluronate. And subsequently, towards the end, you can see with the IOCT how much the bald in this case. Like this is 550 bald, which is so adequate in these cases nowadays. Similarly, you can see in a post-op time, the entire area can be seen. Outcome-wise, iris fixated, this is my series. We did have a good result, but almost 25% of the cases we had to do resurgery, and that caused endothelial cell loss. But if you look at the ICL results by various people, 100% efficacy getting 20/20. Predictability plus by the 0.5, more than 95%. Safety 1, bald almost 400 plus. Complications hardly any there, and the endothelial cell loss is 4.4% at 3 years. That's a wonderful results with the phakic ICLs. This is a meta-analysis of 5 RCTs looking into a phakic IOLs with central hole, which is the new design, is very effective, as good as previous lenses. For low myopia also, comparing less than 6 and more than 6, the results are excellent. And long-term results also, you can see the ball goes down a little bit, but it doesn't cause any visual acuity problems. There's an expansion of range, which I think is important to understand for all of us. If you look into this particular slide, the application has gone to low myopia, keratoconal, piggyback IOLs in pediatric cases also. So I would say, to summarize, this is a very effective way, and in future it is going to stay because it gives you a wider range of application in practice for a refractive surgeons. As far as I'm concerned, I'm 3.47 minutes. Thank you, sir.
Thank you very much, sir. Very nice talk. Vardhan, are you ready to go?
Yes, sir. So I'm sharing.
Okay, please start.
Yeah. So thank you, Dr. Agarwal, sir, and Star, for the kind invitation. So I'm going to talk to you about how do we maximize the surgical safety and surgical efficacy. One thing I would like to maintain here is that previously the age was 21 to 45 years. Now it has been expanded to 21 to 60 years. And now the minimum internal ACD has also been reduced from 3 mm to 2.8 mm for our star ICL. First and foremost important thing is that the loading of the ICL. The loading of the ICL is the most important and of paramount thing if you want to have a successful outcome. As we know, ICL has this center of flow hole in the center, but it also has the leading right hole and the lagging left side. You should see the hole. So when you take the ICL from this foam tip applicator, make sure that you roll it in very, very nicely in this cartridge on what is called as the docking station. On this docking station, you nicely put it in. All the holes should be aligning with each other very well. The ICL holding forceps. Make sure that it is also aligning with the central hole, and then basically you have to have a push and pull at the same time. So once your IC is loaded, then you go to your eye. Make sure that you have a incision which is parallel to the iris. There are going to be, of course, two incisions for paracentesis, and there is going to be one incision which is the main port, which has to be 3.2 mm when you begin your surgery. The viscoelastic of choice is going to be HPMC. Make sure that you don't overfill it. And once that is done, you go with your keratome of choice and then create a 3.2 mm incision. Make sure again you're parallel to the iris and you're not dipping in like in cataract surgery. So this is very, very crucial. The ICL injection is something which is very important. Make sure that it is slow and steady. You should see the leading right hole on the right side, and the left side lagging hole should be there on the left side here. Then this is what we call this as Mickey Mousing. Once the ICL has been put over the iris, and especially if it is a toric lens, make sure that you are aligning it very well. Make sure that you don't touch the optic, but just align it with the help of the haptics and the body. Once they are well aligned, then you have to tuck it in, and once you have tucked it in, you can alignment, especially the lenses, looking at the printout that you have. And once everything is in place, make sure that you have removed the viscoelastics gently and nicely. Then at the end, of course, you close the wound. The total procedure should take close to less than 3-4 minutes. There are two things that I would like to tell you, which are actually our modifications. We have started to do what is called as the angle incisions now for the paracentesis, and majority of my procedures are now hydroimplantation of the lens. You can see that this paracentesis are actually angled towards their angled incisions, so that we can reach out to the haptics very easily when we tuck them in. This entire procedure should take less than 1 minute. So this is my probably last video, and you can have this intracameral anesthesia in place. You fill the AC with strands of viscoelastics go inside with your 3.2 millimeter incision. And then you actually have to do, this is the hydroimplantation. So I'm going with the irrigation on my left hand, and then I'm going with the implantation of the already loaded ICL on the right hand. Your injection remains the same. This is the ICL which is in place now, and then we tuck it in. You will realize that this saves your time, and also there is no viscoelastic that we have to, like, you don't have to spend time in doing irrigation aspiration over time. And this also reduces your chances of having IOP spike in the postoperative time, as well as no viscoelastic which is trapped between the ICL and your crystalline lens. So this is the method of choice right now for me, and this is how I'm doing all my ICL procedures. Of course, with the COVID, you have to modify all the protocols, and I think in one of these times, the bilateral ICL surgery is one of the things that you should consider. But I think overall, ICL is here to stay, and definitely one of my favorite techniques of choice.
Thank you, Varma. Thank you very much. We have two of the panelists. One is one of the panelists is Dr. Hema, and the other is Dr. Swapna. Any comments from Dr. Hema and Swapna?
Nothing much, Dr. Vardhaman, regarding implantation of the IOL. I would be a bit wary in using, that kind of pressure and irrigation virgin lens, and with that kind of an endothelial count, where I expect not to intervene for the next, 40 years. So have you had any problems regarding anterior capsular opacification or anything of that?
Not at all, actually. It is not that there is no visco in the AC at all, because we always use the visco when you make the main port, right? But the thing is here that we don't overfill the visco again when you are implanting the lens, and you have the irrigation in the left hand already. So while you are implanting, majority of the viscoelastic will also get washed out. And basically, once you have the haptics which are tucked in, it reduces not only your time, but also it reduces chances of visco being trapped between the lens and the entry capsule. I've been very, very happy with this, except for the toric lenses. If I have to rotate the toric lenses too much, then I still go ahead with the viscoelastic implantation, and then I rotate them, I put them in place, and then I will do a traditional irrigation aspiration. But for the non-toric lenses, spherical lenses, this is my method of choice now.
Dr. Vardhaman, Hema here. Hi. So now, do you do anything different during surgery? Like, for phaco, we were speaking about splatter and stuff like that, right? Because of COVID and things. So are you incorporating any changes now, or the procedure is the same?
No, I think definitely we are incorporating changes. I think whatever has been, whatever changes you want to incorporate in phaco, exactly the same changes have to be taken into account even for ICL procedures. So I think, that is just to sum it up. But we have to follow maximum precautions, including intraoperatively during the procedure, and also all the paraphernalia around it.
Correct.
Okay. Any more questions? Okay, thank you, speakers, and thank you, the panelists. Thank you very much. We have really enjoyed it. Thank you. Just in and out. Thank you, sir.
Thank you so much.
I think we are done with the star surgical session now. Now we move on to glaucoma, which is the LSR session. And we have with us Dr. T.P. Lahane, who really doesn't need an introduction. He would be moderating the show with and the panelists would be Dr. Tanuj Dada, Dr. Namrata, and Dr. Priya. Over to Dr. T.P. Lahane, sir. Dr. T.P. Lahane, are you there, sir? So we would be starting with Dr. Tanuj. Is he there? Dr. Tanuj Dada?
Yes, I'm here.
Yeah, I would like to introduce Dr. Tanuj Dada, who is at the RP Center in the glaucoma unit. And he would be coming out with a very interesting talk targeting the brain in glaucoma. Over to Dr. Tanuj, please.
Just 15 seconds ad, then you can start your program, sir.
Can I start?
Yes, please go ahead.
We have 6 minutes, no?
4 minutes, sir.
No. They emailed me.
We have 6 minutes. We have 6 minutes for this.
Sorry.
Okay.
Yeah.
Sir, 15 seconds ad, then you can start your program, sir.
So you'll have to stop sharing the screen. Probably then it will play.
Oh, should I start or should I wait?
We have to wait for the promotion.
Now you can start, sir. Thank you.
Okay. So the topic for today is targeting the brain in glaucoma, and this is a new concept. I have no financial disclosures, but anybody who's interested in this topic, I would recommend this book, Quest of the Overself by Paul Brunton, onto how you can utilize the brain for the benefit of the human body. So the first concept is that glaucoma is now classified as a neurodegenerative disease because there is a transsynaptic degeneration affecting the occipital cortex in addition to the damage to the optic nerve. So we summarized in this review that the brain is naturally a potential diagnostic and therapeutic target for glaucoma, and we must expand our knowledge in this field. We all know that glaucoma patients have optic neuropathy. In addition, they have a poor quality of life due to an impairment in the psychosocial function. They have higher levels of anxiety, less psychological well-being, and they have an impaired executive function. This is very important because they suffer from dementia and impairment in memory, and that may be one of the reasons why we often say that glaucoma patients are poorly compliant. They often forget to take medicines. So this may be directly related to the damage occurring in the brain with a poor executive function. And furthermore, when you start therapy, due to the side effects, the quality of life actually worsens. So this is an area which we have not been targeting for our glaucoma patients. Now, this is a blinding disorder, and the patients have high level of stress due to this disease. And what has been shown is that due to stress, there is a rise in endogenous cortisol, and cortisol directly damages the hippocampal neurons. So these are the neurons responsible for memory. So increase in stress, increase in cortisol damages hippocampal neurons, and this sets up a vicious cycle. But the good news is that if you decrease the level of stress, you can reverse the lowering of cortisol can be done. And this is very important to reverse the cognitive decline that we are seeing in elderly glaucoma patients. Now, you all know when a glaucoma patient comes to your OPD, you ask the patient, do you take any form of steroids? But what you should also be asking the patient is that does he have any recent psychological or emotional stress? Because these lead to increase in endogenous cortisol, which can be a major factor in the rise in intraocular pressure. Now, what is the impact of meditation on the human brain? In the last decade, it has been observed through MRI studies that there is neurogenesis in the adult brain with meditation, and there is increase in both gray matter and white matter. You can see meta-analysis of 21 neuroimaging studies. So with meditation, actually you have a larger volumes of gray matter, including the hippocampus. And this is very important because actually on neuroimaging, what they found was that the brain of meditators is 7.5 years younger than controls. So this is beneficial for brain preservation, and actually meditation confers a type of neuroprotection to the human brain. In addition, patients of glaucoma have a decrease in the blood flow to the optic nerve and the cortex. So with meditation, you can actually increase the blood flow. You can see visual cortex flow is decreased in glaucoma patients. And this is our study at All Institute of Medical Sciences. We have a new technology which is known as functional near infrared spectroscopy, where you can pick up the oxygenation of the occipital cortex. So what we found was in a randomized control trial that with meditation, you can increase brain-derived neurotrophic factor, and you can actually increase the oxygenation of the occipital cortex, which is very important for glaucoma patients because they are having an atrophy due to the disease. And furthermore, you can see with the short-term meditation of just 5 days, there was an increase in the cerebral blood flow. This is the single photon emission computed tomography scan. So you can actually enhance both blood flow as well as oxygenation. And finally, what about normal pressure glaucoma? These patients have an autonomic dysfunction because they have a sympathetic overreactivity, which leads to vasoconstriction and decreased blood supply to the optic nerve head. This is directly correlated to the worsening of the visual fields, and we are doing nothing about this autonomic dysfunction. So the important point is, can we reverse autonomic dysfunction? So the answer is yes. You can see in this randomized controlled trial, just with 20 minutes of meditation for 5 days, there was decrease in sympathetic activity due to a better regulation of the autonomic nervous system by the frontal cortex. So just by tapping the brain, you can change the sympathetic activity and increase blood flow to the occipital cortex by lowering the levels of plasma catecholamines. So finally, to summarize, this was the first randomized controlled trial in the world in which we published the effect of meditation on glaucoma patients. And you can see 75% of patients had a 25% reduction in intraocular pressure, which was very significant, and improvement in quality of life. But the most important thing is, you can see here a reduction in the levels of cortisol, which was one of the main factors causing the rise in intraocular pressure. There was also a change in gene expression that we did with meditation for 21 days. And this is our recently published article which summarizes the benefits of meditation for glaucoma patients. So we have labeled meditation as a poly pill for glaucoma patients. Just with half an hour or 45 minutes of meditation with deep breathing, you can reduce intraocular pressure, increase the blood flow to the optic nerve, reverse autonomic dysfunction, and have an improvement in the quality of life. So to summarize, in addition to lowering the intraocular pressure, we can target the brain for reducing the intraocular pressure and improving the quality of life. And the goal of the therapy should be to treat the eye as well as the patient behind the eye. Thank you very much for your kind attention.
Thank you, Tanuj. I think it was some very different type of thing that meditation is definitely helping. And I think this, what you say, the oxygenations and all other things which is happening because of this meditation, that is really something new in the glaucoma.
Yes,
I really appreciate.
Thank you.
I think the at the end we will go for the question and answers.
Sure.
I will invite now Priya Narang. I think she doesn't need any introduction, and she is going to speak on the new technology that is AVA. Priya Narang.
Yeah, thank you, sir, so much. I hope my screen is visible.
Yes.
Yeah. Good evening, everybody. At the outset, I would like to thank Dr. Ramar Agarwal for giving me this brilliant opportunity to talk upon AVA. AVA, we all know, we have labeled this, it's an advanced vision analyzer. And It is actually a virtual reality automated perimeter. As you see this device in the picture, it has 4 basic components. The one that you see in the center, it's a head-mounted device which the patient is supposed to wear on the head. On the left is the patient response button. We all are accustomed to the patient response button because all people who are doing perimetry, they are used to this. On the right side, what you see is the test control device. Now, this is a tablet, and the entire information regarding the test and everything is there into the test control device. And there is also a backend cloud server which stores all the data of the patient, and it has various other advantages which I'll come up to. So the basic key features of the device are that EVA, it offers a white-on-white perimetry, and it has a lens holder for provisions for placing lenses that helps to correct the refractive errors of the eyes being tested. It also, the interpupillary distance can be adjusted for the cases. The HMD, the head-mounted device, has a knob with where the IPD of the patient can be adjusted. The key feature about EVA is that it also has an eye tracking subsystem. Now, this eye tracking subsystem is one of the plus points of the device. It has 2 infrared complementary metal oxide semiconductor cameras which are placed for each eye, and there is an array of infrared LEDs which is used to illuminate the pupil of the patient. So in fact, actually you can track the pupil, and there's an eye tracking system which is there inside. The stimuli which is presented in the device is the Goldman size 3, although for 2 to 5 Goldman size is available. To ensure a reliable test, there are catch trials which are incorporated into the testing strategy. And we all know that having a catch trial is very important for any new device, because that is how we keep the false negative positives and the fixation losses into check. And these are the reliability parameters which go a long way to interpret the visual field. So, and the cloud-based storage system, which I was just talking about, all the data of the test which is recorded, it just goes up to the cloud system, and that is where all the test report information is stored, and you can easily retrieve the report as and when it is needed. Plus, you can even mail it to your doctor. Suppose if you're doing a test in the periphery, you can just mail and take the opinion of any surgeon across the world with that. So that's one plus advantage with that. So it can be used for screening also very well in remote areas, especially for our country and abroad also. And the data of all the reports, they can be easily accessed to the test control device. So I'll just show you a small video, which will just give you a brief into what the device is like. This is the head-mounted device, which the patient wears it. It has an adjustable headband. This is very light in weight. It's just 500 grams. This is the test control device. The patient response pattern is connected to the head-mounted device, and the test control device actually it helps you to feed in all the data inside the eye. So this is I'm just pausing this because you can choose the strategy that you want to put into. You can choose the eye and various other parameters, the refractive error, and you can just set it, and you can just fill in other patient details which you want to do for your patient, and the test is conducted. So this is an eye tracking system which is there. It helps you to monitor the gaze of the patient. So coming up to the device, the program and the strategies which are incorporated are the 30-2, 24-2, and the 10-2. We all are accustomed to this. The specialty is that, it has newer algorithms which are there inside the eye. The ELISAR Fast, the ELISAR Zest, and the full threshold. The ELISAR Fast is a screening program. Now, this is quite similar to the Humphrey, where we are using the CETA Fast. So, but the algorithm has been specially designed. It's not exactly the similar thing. There is an ELISAR Zest. This corresponds to the CETA standard, which is almost a standard method of doing perimetry as of now. So we all are almost using it. And there is a full threshold program which has been set into the device. The Zest program, the ZP estimation of sequential threshold, is already an existing algorithm, which is there in many of the devices. But there are certain changes which have been incorporated into the into this program, and that is why it is known into this algorithm, and that's why it is known as an ELISAR Zest. It's the way that the next stimulus comes up, and it's the way that the test ends that makes it much more reliable and good. So I'll just try to show you this field report. You can just see how I'm just comparing it with the Humphrey because we have just ended up doing some studies of the comparative analysis. So you can just see on the left, we have a report of the AVA, and on the right, we have it for the Humphrey, and it's an ELISA fast program, and this is the CETA fast on the right side. And things are quite looking quite similar. The mean deviation, the pattern standard deviation, the hemifield test, and the on the left side, I mean, what I'm trying to say is that there is an equivalence of the test and of the algorithms for both these devices. And similarly, it is for the ZEST and other things that we have done. The good thing about the device is that there is an ongoing development for the progression analysis, and there will definitely be an EMR integration also into the device. So just wrapping it up, I would like to say that there are various advantages with this device, that it's portable, it does not have a learning curve. We all are used to using this, except that we just have to wear the head-mounted device, and it's a virtual reality. There's an accurate detection of visual field effects. It's quite cost effective. It's almost 1/3 the price of a normal standard automated perimeter that you have. It can be used for screening in rural areas or in any other areas. You need not have your patient sitting into your chamber and doing this test. It gives a lot of postural freedom. Even the patient can do the test in supine position or whatever is comfortable to the patient. The most important thing that I would like to highlight for this AVA is that, especially in this current pandemic situation and the post-COVID situation, the advantage is that you can perform the perimetric test with the mask on. So it gives additional benefit to both the perimetrist as well as to the patient. The patient can wear the mask and do the test. So there's no, there is quite a safety, and you can maintain the physical distance also. So these were some of the brief things. I think if anybody has any question, you can please email me. My email ID is there because at this platform, I cannot keep on talking everything. So thank you, and I'll be too glad to reply to any of the queries. Thank you so much.
Priya, thank you very much for an excellent presentation. I have seen this AVA here also, where demonstration, and I think that is a really useful. So we are going to take questions in the last. So now I will call the Dr. Neil Israeli. Now he is going to speak to us on the minimal invasive microsclerotomy. So Neil, please go ahead.
Okay. Can you see my screen?
Yes, I can see Neil.
Okay, so good evening from Israel. And first of all, I would like to thank Dr. Agarwal for inviting me to present in this conference. So my name is Nir Israeli, and I'm the CEO and co-founder of Sanoculis. Sanoculis is developing the MIMS device and procedure, which creates a sclerocorneal drainage channel to reduce the IOP in glaucoma patients. MIMS stands for minimally invasive microsclerotomy. It is a simple, fast, and stentless procedure with efficacy similar to the gold standard trabeculectomy. I'm going to present a short video describing the MIMS procedure. Just a moment. Here. Our system is comprised of foot switch, controller, and disposable handpiece unit with a special design drill at the end that goes automatically out and backward. And the procedure goes like this. The physician creates a side port, then inject viscot under the conch, and then introduce the device ab interno to the eye angle. Once in position, press the foot switch and the drill goes out and backward, taking a piece of tissue, creating the sclerotomy to drain the aqueous from the AC to the subconjunctival space. The piece of tissue remains inside the drill. This is one of the latest surgeries conducted in Europe. As you can see, the physician injects viscot under the conch and then create the side port and introduce the device to the angle. No need for gonio lens here. It's all visualized through the transparent cornea. Once in position, press the foot switch and you will see the drill beneath the transparent conch. And that's it. A very fast 2-minute glaucoma surgery. MIMS fits most glaucoma patients who need surgery. Similar in efficacy to the gold standard trabeculectomy or subconjunctiva MIGS, but with better safety profile due to its minimal invasiveness and the fact that nothing is left behind. I'm now going to describe the clinical status of MIMS. So far, we operated on 151 patients under post-market study protocol, and the highlights of the results are impressive. In India, we have done 31 cases. This is the final report with 12 months follow-up. As you can see, 50% reduction in IOP at 1 year and 58% reduction of number of medications at 1 year. Procedure very fast, 2 minutes on average, with no major intra and post-operative complications. In Europe, we have done 120 cases. It's an interim report with the first patients arriving to 12 months follow-up. As you can see, 46% decrease in the IOP at 1 year and almost 100% decrease in number of medications after our procedure. Again, a very fast procedure, 2 minutes procedure on average with no major intra and post-operative complications. These slides depict the success achieved with MIMS in India. The IOP was reduced significantly from 31.2 to 15.6 millimeter of mercury after 1 year. In addition, the number of medications was also reduced significantly by 58% at 12 months. This slide depicts the success achieved so far with MIMS in Europe. The IOP was reduced significantly from 27.9 to 15 millimeter of mercury after 1 year. As you can see, 30 patients already arrived for this milestone. The number of medications was reduced dramatically by 98% after 12 months. The pictures prove the concept of MIMS. The channel stayed open 1 day post-op and 6 months post-op. Professor Aik Ahmed, a leading key opinion leader in our field, recently conducted 11 procedures with MIMS. This is what he had to say about it. It is a very short learning curve technique, safe, and alternative to the stent procedures. It can be easily combined with cataract surgery, fits most glaucoma patients, with efficacy similar to the gold standard trabeculectomy with less side effects. The fact that nothing is left behind keeps future therapeutic options open, which is a major advantage in this field of glaucoma. Sanoculis is backed by a distinguished list of experts from around the world, which I'm sure you are all familiar with. The roadmap presented in this slide represents our plans for the near future, with the immediate step of launching the product in Europe. MIMS has numerous advantages. The important ones are outlined in this slide. For these reasons, we at Sanoculis believe that it has a potential to become a very attractive treatment for glaucoma patients worldwide. Thank you very much for your attention.
Thank you very much, Neer. I think a very good procedure and excellent. I think you have shown the video and really some new innovation in glaucoma. I'm very happy to look at that. And also you have shown the experience of the surgeons. I think really this will path breaker in the glaucoma, because in glaucoma there are, because it is a chronic disease and there are so many problems. So I think that is an excellent thing, and we will discuss this at the end. And now I am going to call none other than my best friend, the excellent phaco surgeon and the very good human being, Dr. Haldipulkar. And sir is going to speak on the high frequency deep sclerotomy. And I'm proud that he is from Mumbai. Dr. Suhas Haldipulkar.
Thank you so much, sir. Thank you so much. I'll share the screen. Is my screen visible, sir?
No, screen is not visible. You go to the share screen.
I have.
The technical team, please have Dr. In Hall D, Dr. Haldipurkar. Technical team from IRIS, Hall D. The Haldipurkar is unable to share the screen. Please help. Is it possible, sir, Haldipurkar, sir? The technical team? Yes, yes. Now I.
Can you see it now?
No, I don't know what has happened, but it is seen. My photo is seen. So I think something is wrong. The who is there in technical team, please? Please help us. I think your share screen. Rohit, there is some problem in the technology. He is unable to share the screen.
So what should we do, sir? Do you want to hold some discussions for a minute?
Yes, that will be better. So we will ask the questions.
Yeah.
That will be better. Priya, as you have presented the AVA technology, which is for the perimetry, and I think that is an Indian-made technology, which is very useful in the camps also outside, yes. And nothing is required in that. Can you tell me what are the silent features in that?
The salient feature about this is that I would say, which is very important, is that it's a portable device. So that's a very great advantage. You do not need any specific sitting area in your hospital or in your clinic or a separate room. In fact, a dark room that you don't need for this device. That's a very big advantage. The second advantage that I said, I think this has come up.
Yeah, I think. Yeah. Please.
Yes. Second, tell. Haldipurkar sir, 2 minutes.
Right. Okay. Please. So the another advantage with the device is that, as you said, even we can impart the advantage of doing perimetry in the peripheral areas, in the rural areas. There are, it's we all know it's a blinding disease. So that can be very helpful, very advantageous especially for our country or any developing country, where the medical services, they do not happen to reach into the periphery of the country. So that's another advantage with that. It's very cost effective as compared to any other device. So that's also another major advantage. It's easy to your pocket also. And the best thing is that, there is the field reports which are generated. They are quite in equivalence to what we are used to seeing with the other standard automated perimeters. So that is another advantage, that we have a high reliability index also coming along with the device. So I think these are some of the key features. And what I said was that you can even with a mask, even you can do it. So it's quite safe. You can be safe from the dispersion of the bacteria or the viruses and all that. So these are some of the key advantages that come up with the device.
Thank you, Priya. Now I will go to Dr. Haldipurkar. Now he can share the screen. Haldipurkar sir, please.
Yeah. You have my screen there, right?
Yes, we can see the screen, but your video is off, sir. आपका video चालू कर दो. Video is off.
No, but my this thing is on, na? The present.
Yes, presentation is on. You can go ahead.
Okay. Thank you so much, sir.
We can see you. We can just listen to you.
Yeah.
Okay, go ahead. No problem. Go ahead.
This talk is on high frequency deep sclerotomy, a way forward for mild to moderate. I have no financial interest there. Trabeculotomy is still the gold standard for surgical treatment for glaucoma, but is often written with issues like post-op complications and occasional failures. So MIGS fits the bill. Because it's minimally invasive, conjunctival sparing, need lesser number of follow-ups, and sometimes it's easy to perform like the one you saw just now. HFDS or high frequency deep sclerotomy, the device used for this is earthly phaco system, heavy glaucoma probe with specially devised platinum tip, and a direct gonioscopy lens. The target point for the application is iridocorneal angle opposite to point of entry. It's applied after the completion of cataract surgery with intraocular lens already in place and the pupil narrowed. The use of this passive viscoelastic to open up the angle just before doing this HFDS is useful. HFDS is performed using high frequency diathermy probe, which cuts the tissue and creates an opening from anterior chamber into the Schlemm's canal, and it creates a hiatus like you see in the picture. And to do that, what we use is called heavy tip. It consists of an inner and outer coaxial electrode. Both electrodes are isolated while the inner one is made of platinum. If you look at this animation, you get an idea of how exactly this procedure is performed, either as a primary or along with combined cataract surgery. You attach that probe to the phaco machine, use a 4-mirror or a single mirror direct lens. If you're doing with cataract, constrict the pupil after the implantation is put, viscoelastic is filled to open up the angle. And the angle, the iridocorneal angle is where the probe enters and creates a hiatus, and it is done at 6 different places. And this, in simple words, is how it is done. And to do that, we can use either the 4-mirror as it was shown there, or we can use the single mirror ocular lens. After the eye is filled with viscoelastic, the probe is introduced inside. The lens is placed on the cornea, and there you see the angle under high magnification with the lights in the theater put off. You can actually see the angle. Sometimes if there are synechiae, you can clear the synechiae. You prefer to do it in an open angle glaucoma. The end point is when you see the champagne bubbles and a small sound, and such punctures are made at 6 different places from where you are entering with the probe. The probe enters through a 0.9 opening. Sometimes you may have some blood in the angle, or when you make your puncture, if there's a bleeder, you may get little bleeding. You may even have to use viscoelastic to clear the angle midway through the surgery. But this entire procedure takes you 1 or 2 minutes. It is done normally at the end of the cataract surgery. It can either be done as a primary procedure, but in the cases that we have done, we have preferred to do it as a combined procedure. The target deep sclerotomy pocket is approximately 0.3 millimeter thick and 0.6 millimeter wide, resulting in a resorption surface of 3.6 millimeters square. What are the advantages of HFDS, which is also one of the MIGS? It leaves a virgin conjunctiva for later use, potential minimal trauma, a high level of safety, and short learning curve. Faster visual recovery can be combined with cataract surgery. We've been doing it for quite some time. Now, this is a study of last 3 years. We took up 130 patients who underwent HFDS procedure. They were followed up for 3 years. The median age was 62. The ratio of male to female was 55 to 45. The mean IOP was around 18.7 millimeter of HG in right and left eye respectively, preoperatively with an average of 1 anti-glaucoma medication, which remained between 16 and 16.5 millimeter without medication for the next 2 years. The number of anti-glaucoma medication reduced from 1 median with interquartile range of 0.1 to 0 post-surgery and remained so for 2 years. The number of medications required at 3 years was 0.5 median with interquartile range of 0 to 1. So these were the patients who were on medication, who were taken up for cataract surgery, And we wanted to ensure that after the cataract surgery, they were off their glaucoma medication and a drop in the pressure of nearly 5. And this was successfully, and this procedure seems to have a lasting effect. In the earlier study that we did, it had the effect lasted for more than 10 years. So in conclusion, HFDS is a safe and has good long-term results, can be used in early to moderate PO aging, cannot be used in close angle. And thank you so much for this patient listening and an opportunity to speak here.
Thank you very much, Dr. Haldipurkar sir. I think it was an excellent presentation, and now our topic is open for the discussion. So I will, the Rohit has also joined. So I will ask first the one setup question to everybody, and then I will hand over the mic to the Rohit. So I will ask the first question to Tanuj. Tanuj, I think your presentation was very good. In that, really, you have told that how the meditation is helping, and secondly, how the glaucoma is affected in the you can say, neurons in the brain. So you tell me what it means. What is the duration of the meditation? It is done, or is that meditation helping in female only or male? How that is helping? So please guide that.
So thank you, sir. So I think the first concept to understand is that many glaucoma patients we found have high levels of stress, and that raises endogenous cortisol. And the endogenous cortisol causes rise in the intraocular pressure. And we were not aware of this before. So when we checked the blood levels in some of our glaucoma patients, cortisol was very high. So we asked them to undergo a therapy of pranayama and meditation. So basically, for half an hour to 45 minutes, you just focus on slow, deep breathing. So what happens when you focus on slow, deep breathing? It is both for males, females, any age group. And it is especially for elderly because they cannot do exercise. Many of them are on wheelchair. So just simple breathing and meditation for half an hour to 45 minutes. What happens is that when you do this, your autonomic nervous system starts changing. So you have increase in parasympathetic nervous system, and the sympathetic overdrive goes down. That is responsible for vasoconstriction. So you have subset of patients who have got decreased blood supply. Pressure is not high like normal pressure glaucoma. So the main cause is vasoconstriction. So there it is very helpful. Secondly, I told you cortisol was very high. So when these patients did this meditation for 3 weeks, cortisol levels came down and we had 20-25% reduction in intraocular pressure. And many of the patients were scheduled for trabeculectomy because of very high pressure. And with this intervention, they could reduce the intraocular pressure despite being on maximum medical therapy, and they got off the OT. And finally, it has got lot of benefit for the holistic health of the patient. Like glaucoma patient, they are under stress because they are getting blind. We are just giving medication or doing surgery, but you need to approach the patient as a holistic human being. So with this lifestyle changes, it can help glaucoma patients. And now with the evidence that is there, it is lowering blood pressure, increasing ocular blood flow, increasing the brain blood flow, increasing oxygenation to the occipital cortex, and generally improving the well-being of the patient. So it is a very good adjunctive therapy. You continue your medical therapy, whatever you're doing. If patient does for half an hour, 45 minutes, it changes the overall well-being of the patient and reduces intraocular pressure. And it has no expense. Anybody can learn this. It doesn't require any special place. You can do at your home. And I think this is our traditional Indian yoga and meditation for last 5,000 years. And now we are discovering it is so beneficial for our patients. And it is very proud that in India we could do this research and find out that this 5,000-year-old technology is so good for our patients.
Very good. Tanuj, I think what you told is very correct. Namrata has joined Namrata, welcome. The session, we have finished the presentation. We are at the discussion. And now I will ask the Neer. Neer is from Israel and he is from the Sanocolis, this company. Is presented the MIMS. Neer, my question is that what is the, you can say the diameter of that probe and how much length you are going inside the sclera? And is that the injury is happening to the, you can say ciliary body or perforation is happening in the sclera? So that is what I feel.
The diameter of the channel that is created is around 90 micron on average, and the length is 1000 micron.
Okay. So any injury around?
No.
No
injury around.
Okay. And is that getting a fibrosis after few years, few months, you can say? Incidence of fibrosis.
We prevent these from the inside. There is no scarring because of the fluids, the aqueous that flow through the channel. And to prevent the fibrosis and scarring outside, we inject mitomycin C 1 hour before the surgery. And so far, so good.
Okay. Thank you, Nate. So I will ask the question to Dr. Haldipurkar sir. The Haldipurkar sir, I think this diathermy you are using, that is a 0.9 of the diameter, and you are making 6 holes. You tell me, are these holes getting fibrosed, and how much pressure? You told me that is 0.5 pressure is reducing down, and is that the medicines to be continued, or medicines are not required after doing the this HFDS?
Okay. Now the probe goes through 0.9, but what actually that glaucoma tip, it only goes through 0.3. The thing is, this procedure is an adjuvant to cataract surgery, or when you have mild to moderate glaucoma, because the so far what we have seen is that effect of HFDS is to the tune of 6 to 8 millimeters. And when it works beautifully, and the effect lasts forever. It's just that if the passage that you have created is closer to the collector channel from the Schlemm's canal, then it works more effectively. That's the reason we create 6 of those channels, because even one channel closer to the collector channel is good enough to give you a sufficient drainage.
Thank you, sir. Thank you. Rohit?
Yeah, thank you, sir. Thank you for the taking over and having an excellent session. So now we move on to the next session, which would be the Novartis Symposium. And this Novartis Symposium would also focus on different aspects of glaucoma, wherein they would put forth how glaucoma can be managed by the way they want, they have come out with. I hand over to Ronnie George from India, who would be moderating this session. Over to Ronnie for this session from Novartis on glaucoma. Ronnie, please.
Thank you, sir. So we have a interesting session today with 4 speakers.
Dr. Ronnie, please be a minute, sir. After 15 seconds, your program can start, sir.
Okay.
Thank you, sir. Thank you, Dr. Ronnie. Just you can continue, sir.
So thank you, and welcome to this Novartis Symposium on glaucoma. We have 4 speakers, and without further ado, since we're running a little late, I'll request my good friend Murli Ariga to speak about Micropulse diode CPC, a game changer in glaucoma management. Murli, over to you.
Yeah, good evening, and thank you, Dr. Rani. My sincere thanks to the organizers of IIRSI and Novartis for the symposium. I'm going to speak today on the role of the Micropulse diode CPC. Could it be a game changer in glaucoma management? Cyclodespective procedures in the past have used ultrasound, cryotherapy, lasers, and among the lasers, the diode laser seems to be the best as far as the effectiveness, portability, and ease of use and so on. And earlier we were using what is called as the transscleral diode laser with the G probe, and all of us have used it for many, many years until recently. And the G probe actually is a fiber optic tip which protrudes behind the anterior edge of the foot plate and protrudes a little bit. And this is the setting which we're all familiar with. You give a block and you do the laser. Complications with the continuous diode CPC have been conjunctival burns, iritis, vitreous hemorrhage, hypotony, choroidals. Rarely even sympathetic ophthalmia has been reported. The newer Micropulse laser cyclophotocoagulation uses a duty cycle of 31.3%, and this Micropulse technology denatures the target tissue while minimizing collateral damage. A series of short repetitive bursts of energy confines its thermal effect to the absorbing tissue, and the probe is applied in a sweeping movement, as you can see on the picture on your right. I'll show you a short video clip of how the procedure is done. It is usually done after a local anesthetic like a peribulbar block in the operation theater with monitored anesthetic care, and use a microscope with all the precautions which you normally follow. And this is how the sweeping movement is done over the conjunctiva. You make the marks and you sweep inferior and superiorly. And this is another picture of the same procedure being done in the OT. The settings are 80 seconds superior, 80 seconds inferior. You avoid the 3 o'clock and 9 o'clock. The energy is about 2000 milliwatts. And some of the examples of eyes whom I have treated recently: uncontrolled PACG despite YAG-PI and maximum medication, intolerance to medication like this with periocular redness, severe hyperemia, prostaglandin intolerance, and so on. Post-AGV, post-phaco trap, still the pressure is very high. In this kind of situation, in seeing eyes, you can do the procedure. And similarly, in the Boston K-Pro, in which the pressures are very high and progressive glaucoma, you don't have any choice but to do procedures like the Micropulse CPC. Post-laser, you continue the medication for glaucoma for some time. Intraocular pressure usually gets controlled in a few days, maybe at the most at the month. The response is quite good to the treatment. You get a pressure lowering of about 25 to 30 and even 35% IOP lowering. You don't need steroids and cycloplegic for some time to control the pain and discomfort. Some of the problems with the Micropulse CPC include cost and logistics. So the single probe, which can last once it is connected, lasts for about 90 minutes and it's expensive. And the myofibrin reaction, which you may get in some patients. A slight vision loss can also occur in some patients. In some patients, the pupil remains dilated and there can be a mild epithelial haze in some few patients. But hypotony and choroidals are extremely rare. I have not encountered one in the last 2 years. And you should avoid treating areas of thin sclera, blood clots, and recent post-ops are not good patients to treat with the Micropulse. A lot of literature available: Academy, Journal of Glaucoma, Survey of Ophthalmology, all recent publications about the use of the Micropulse transscleral CPC in glaucoma patients. And our own study results have been published recently, going to get published recently. And in this, we have found the IOP lowering of about 30% and a reduction of medication from 3.3 to 2.1 medications. So the reduction in medication is definitely possible. How does it work? There's a subthreshold cell damage at the level of the pigmented ciliary epithelium with no scarring, an increase in the uveoscleral outflow, and maybe a pilocarpine-like effect. So a brief take-home message: the Micropulse CPC is very effective and a safe alternative to the continuous wave CPC. Can be used in moderate advanced glaucomas and also eyes with good vision and not just intractable glaucomas like in the past with very poor vision potential. Reduces the need for medication with fewer complications than the continuous CPC. Better to avoid in recent surgery and inflammation. Of course, we need to look at the long-term studies and see how long does the effect last. Thank you for your attention.
Thank you, Murli, for covering that so elegantly and well within your time. I'm going to be speaking next, and I'm going to be speaking about managing your glaucoma patient beyond IOP control. And I thank the organizers for the invitation. So basically, one of the issues with glaucoma is now we know that glaucoma is just beyond, glaucoma control is not only beyond this, it's beyond intraocular pressure too. And if you attended the last session, you would have seen Tanuj's excellent talk on meditation also influencing intraocular pressure. But when we look at conventional treatment, what we need to realize is that non-intraocular pressure dependent risk factors also play a role here. But before you go to non-intraocular pressure risk factors, you have to make sure that you have taken care of the intraocular pressure related risk factors. And there's this danger of relying on a single intraocular pressure measurement to figure out whether things are happening. Once you rule out IOP as a factor, you can look at the rest of the factors, and intraocular pressure factors that are important include both IOP fluctuation and the peak intraocular pressure. Keep in mind that about 1/3 of IOP, 1/3 to 2/3 of IOP peaks occur outside of office hours, and you can miss it in your glaucoma patients. In fact, studies have shown that 24-hour monitoring of IOP resulted in a change in therapy in almost 80% of patients. When you look at the other one factor that matters is the ocular blood flow. And I'm going to start with one example here, which is a little extreme example. It's of a 78-year-old lady, diabetic, hypertensive, with IHD, diagnosed with POG, who had undergone a trabeculectomy. She had good vision and intraocular pressures were consistently okay. We had been following her for a while, and you can see that her fields were more or less stable. Then she started presenting with disc hemorrhages. On 2 separate visits, a couple of months apart, she presented with disc hemorrhages, and her fields started taking a downward course. At this point, we were fairly suspicious, and we asked for carotid Doppler, which showed a 90% block on the left side. Once that was taken care of, her glaucoma stabilized, and she continued to be stable. So what this shows you is the impact of severe impact on blood flow on the nerve. But we are more concerned about what happens locally to the optic nerve. How does autoregulation take care of your blood flow? And how does it impact or decrease vascular resistance? In fact, low ocular perfusion pressure is a predictor of glaucoma progression and is associated with almost a 50% greater risk of glaucoma. And there is data both from suggesting that glaucoma patients have a lower ocular blood flow, and also that patients with a lower ocular pulse pressure are much more likely to have glaucoma than otherwise. When you look at the various treatment options with respect to ocular perfusion pressure, you find that travoprost increases ocular perfusion pressure during the day, just like all the other prostaglandins. The timolol dorzolamide fixed drug therapy also actually increased perfusion pressure. The brinzolamide rimonidine combination does not really increase perfusion pressure, but does not reduce it either. The fourth perspective that you have is trying to prevent retinal ganglion cell death, and this is basically because of the neuroprotection concept that you have. And while multiple things have been tried in the neuroprotection sphere, what you realize is that there is little evidence that any of them is effective. So when you look at this, you realize that the one thing that's important here to prevent retinal ganglion cell delay is actually intraocular pressure reduction. And if you look at the slide here, this is from a paper published some time back. And this is somebody who develops glaucoma at the age of 50, and you can see how the untreated course changes. If you detect him at 55 and start treating, this is what happens, the green arrow. The orange arrow, if you detect him at 60 and 65 and untreated. And what you can see here with the bars are the number of retinal ganglion cells that are lost, depending on when you started treatment or if he was completely healthy. And you can see here too that what we keep emphasizing, that the best way of controlling of neuroprotection at this point in time is actually intraocular pressure control. So while intraocular pressure is not the only risk factor, it is an important risk factor. But when you have evidence that your patient is not doing well, you need to look at other factors such as the 24-hour intraocular pressure. You need to look at ocular blood flow, and you need to look for associated factors which could predict progression. Keep in mind that successful management of glaucoma is beyond just intraocular pressure, and you need to look at the patient as a whole. Thank you. And could I request Dr. Ram to share his slide?
Yes, sir. Yes, sir.
Are you able to see my screen?
Yeah, we can see your screen.
Okay. Thank you, friends, and good evening, everybody. I thank Novartis for giving me the opportunity. I'm going to talk on therapeutic care after cataract surgery. One minute, it's not moving. Ani, super. Move press this. Yeah.
It's moving.
Scroll. Okay, I am going to talk on postoperative cataract care. Cataract is one of the leading causes of blindness and the most commonly performed surgical procedure. More than almost 5.1 million surgeries are performed annually in India. With the kind of pandemic here, again the backlog is going to increase. And the most postoperative complication cataract surgery is called discomfort postoperatively, the bruising or swelling. This is taken away with the peribulbar injection. Most of the surgeries are performed topically. Even the subconjunctival hemorrhage, except in the case of a femoral cataract, most of the surgeries are performed topically. This is also gone. Sometimes allergic reactions are there. Increased intraocular pressure, flat anterior chamber if the side ports are not managed well, and DM folds or the corneal folds, so it's happening because of the high energy usage of the density of the cataract is more following a postoperative emulsification. Decentration or dislocation of the implant or endophthalmitis, a dreaded complication which is grossly reduced because of the various measures taken by AOS and IIRSI and other people guiding us with various state conferences, helping us to give a standard OT protocols and other things. And TAS, which is mainly because you leave out the viscoelastics here and there. And late complications like cystoid macular edema, because most commonly seen in case of diabetic populations or the high energy usage or retinal detachment or late complication of posterior capsular opacification. Basically, we can divide it as infections. It can be because of inflammation or because of cystoid macular edema. And most common complications are infections and inflammation, which leads to significant morbidity and distress to the patient as well as to the doctor. He'll have a lot of stress on explaining to the patient and severe visual impairment or blindness. The cystoid macular edema, most important postoperative complication following cataract surgery, compromises the result of cataract surgery. If you don't identify it in a very early stage, sometimes, most of the times, it forms into a scar or something like that in the retina. The recovery of the patient becomes very bad. It can even happen not only in a diabetic population, even after an uneventful cataract surgery, but the incidence rapidly increases after complicated, either a posterior capsular rent you have, or it can almost happens in both cataract surgery as well as in the vitreoretinal surgery. The risk factors associated with poor postoperative visual outcomes are diabetic retinopathy, glaucoma, age-related macular degeneration, or in case of uveitis, previous vitrectomy, intraoperative complications, either a rent or a touch in the iris, or an older age, even a smaller pupil. So identifying the patients with the risk factors, very important in taking the patient necessary steps to minimize postoperative complications. The management of postoperative complications is mainly prophylaxis. The most common preventive measures, we can divide it as either preoperative prophylaxis, intraoperative prophylaxis, and postoperative prophylaxis. As you know, the ACRS studies have shown the fourth generation fluoroquinolones are very much preferred. If you take in India as well as abroad, almost 90% of surgeons use either moxifloxacin or gadifloxacin, and moxifloxacin is the most preferred drug. And here I would like to quote, we prefer most of the antibiotics based on our association and things like that. But when it comes to a doctor personally, whether he wants to use an antibiotic, he always prefer a Vegamox. That's what I do. When I want an antibiotic, I always prefer a Vegamox. And the topical corticosteroids also, like dexamethasone, are applied with infection prophylaxis to prevent, minimize, and inflammatory and reaction post-surgery. Even NSAIDs are used in combination with corticosteroid, helps to reduce ocular inflammation post-cataract surgery, either in diabetic as well as non-diabetic patients. See, when you use a prophylactic regimen, it complicates the patient because when it usage of more drops, the antibiotic, post-operative steroids, as well as NSAIDs. When it comes to the second eye, again increases the complexity, further reducing the tapering the dosage. The patient gets confused. And we give an instruction, 5 minutes dosage prior to the surgery, as well as give a 2 minutes gap, close the eye. Again, the patient gets confused, and the patient with concomitant eye disease, patient need to manage 14 drops as well as 4 different bottles, it becomes confused. So the 92% sometimes don't instill the drops properly. Prophylactic regimen is complicated by a number of factors, either patient compliance, inability to correctly instill the drops. And remember, nowadays, only for the surgery procedure, the attender come with the patient. After that, he has to go back to the work, and most of the time, it is the aged patient left alone to apply the drops on their own. Lack of understanding of the importance of prophylactic treatment, proper method of administration, drop storage, they test a tip and dislike of instilling the number of drops multiple times a day. The combination of fixed drug regimen as well as a less drop prophylactic regimen can aid in managing the complications of prophylactic regimen. The important factors for selection of the medications are the potency and the clinical efficacy, the patient compliance, and the dosage regimen. The fixed drug combination helps in reducing the complexity of dosing and fulfill very easy to explain to the patient. So 3 times a day you can use it and the patient follows it. So the role of moxifloxacin 0.5% for prophylaxis. Everybody knows that is very specific against gram-positive, gram-negative organisms as well as other streptococcus and pneumonia. Very easy penetration in the cornea as well as into the eye tissues. Delivers a concentration 1,000 times greater than the minimum inhibitory concentration. Moxifloxacin will be regarded as a superior choice over gatifloxacin based on difference in potency and penetration, the major two determinants of antibiotic efficacy. But of late, even gatifloxacin is preferred by some of the surgeons. Need for more than just an antibiotic, recommended treatment measures require both antibiotics, steroids, and NSAIDs several times a day to manage post-operative complications, which requires patient to maintain independent timing of doses, places additional burden on the patient complaints. So fixed dose combination, that's how they started it, the potential to offer efficacious and safe treatment and advantage such a regimen that is simpler to than administering two separate solutions. Moxifloxacin dexamethasone fixed dose combination as a prophylactic agent prevents both infection as well as inflammation after cataract surgery, decreases the complexity of dosing, improves patient compliance. The moxifloxacin, as you know, inhibits the DNA gyrase and topoisomerase 4, thus the bacterial DNA replication, repair, and recombination is reduced, thus reduces the risk of infection. The dexamethasone inhibits multiple inhibitory cytokines, produces multiple glucocorticoid and mineralocorticoid effects, suppresses the inflammatory response and symptoms. Steroid suppresses inflammation, while antibiotic controls the proliferation of pathogenic and susceptible bacteria. Clinical, I'm going to show on the evidence of moxifloxacin dexamethasone fixed dose combination. I'm going to show 3 studies, either a separate dosage as well as a fixed dose combination following cataract surgery, as well as following LASIK surgery, as well as cataract surgery following Asian cataract patients. The ocular plane, yes, sir.
Can you wind up? We don't have very much time.
Yes, sir. It reduces the inflammation as well as in both the fixed and separate combination, reduces the ocular signs of inflammation, as well as it is also helpful in most of the patients. The dosage almost on the 40th day is same, and there is no effect on the intraocular pressure. And as well as in the post-LASIK also, it reduces the pain, and as well as the burning sensation is not there, and the ocular itching is not there. Most of the patients, ocular pain is reduced, and there is no ocular signs in the eyelid, conjunctiva, and cornea. And I have started using it for 4 years, and I have not seen a single patient with an intraocular spike. Even the study shows reduction in the intraocular spike. Patient complaints and tolerability is much better. This adds it is more convenient, helps in better treatment complaints, patient tolerability is better. And as well as the last thing I'm going to talk is the nepafenag, which is well used to prevent the inflammation which is happening in the macula or in the retina. The nepafenag group acts on the hydrolysis the ocular tissue. This inhibits the COX-1 and COX-2 well and spreads in the vascular tissue, iris, ciliary body, retina, and choroid. Its efficacy helps to reduce the pain and inflammation associated with cataract surgery. And higher concentration, we have got the latest one, which is 0.3%, which is used. And this works well in most of 0.3%. That reduces the inflammation. And it is also compared with 0.4%. I'm not stopping because of the lack of time. It reduces the CME most of the time. And the important slide which I'm going to show is the central subfield macular thickness is almost not increased at all when you use 0.3% nepafenag group, and it is a very convenient single dosage usage. There is no side effect of hypersensitivity, headache, and things. Concluding a fixed drug regimen of the antibiotic and steroid along with the nepafenag 0.3 single dosage, very friendly to the cornea, and they say for 60 days. I stop it on 45th day. Very much essential. The patient is not confused with no drops and just 2 drops and gives a 5-drop effect. Very much essential, helpful to prevent the inflammation and an effective management. I'd like to thank the organizers in the Novartis and the other senior colleagues here. Thank you for the opportunity. Let's just stop sharing slides.
Thank you, Dr. Rao. We'll now move to the last speaker in the session, Dr. Chakravarti, who's got an interesting talk on the enigma of similarity. Dr. Chakravarti, over to you.
Ronnie, can I ask one question, Ronnie?
Yes, sir. We have Yes, sir.
You have a discussion after this?
Yes, sir.
Okay. Last plate, no problem.
Thank you.
So I'd like to thank the organizers and Novartis for this opportunity. I'll be taking you slightly away from glaucoma and cataract. I'll be speaking on the enigma of similarity. Does randomized controlled trials translate into real-world practice? Well, until 2006, many of our neovascular AMD and patients had actually progressive vision loss to look forward to. And there was a lot of anxiety, confusion, fear, and shock in these patients. So the big came with the advent of ranibizumab, which was actually approved for usage in 2006 for neovascular AMD. And moving on, it has proven its efficacy not only in neovascular AMD, but also in diabetic macular edema, in myopic CNVMs, in retinal vein occlusions, and also recently in retinopathy of prematurity. What's even better is that early visual gains with the innovator ranibizumab are maintainable long-term if these patients are treated properly. Well, when we talk about comparing different anti-VEGFs in the real-world scenario, probably the largest data set comes from the IIRSI registry, where 3 anti-VEGF agents were compared head-to-head over 1 year in the United States clinical practice. And this was bevacizumab, ranibizumab, and aflibercept. What's interesting is that at the end of the year, more or less, all these actually needed similar number of injections. What about the improvement in visual acuity? Well, it was pretty similar for the approved agents, ranibizumab and aflibercept. And if you look at bevacizumab, slightly lagging behind here. But what about comparing with biosimilars? Well, of course, the REANAC study is there, which was retrospective multi-center observational study, but it was a study of a duration of 3 months only. And it was a non-inferiority study and had 100 patients. So we decided to do it on a larger scale, evaluate how, the innovator molecule compared with the biosimilar molecule in neovascular AMD. This study had 903 eyes of treatment-naive wet AMD. The innovator group had 726 eyes and the biosimilar group had 177 eyes. And these were all treatment-naive. At least 6 months of follow-up was necessary. No switching between anti-VEGFs was allowed, and any other retinal disease or surgery, and the patients were excluded. Now, besides the primary endpoint of the change in best-corrected visual acuity, we also looked into the number of intravitreal injections that the patients received. Moving on to the results straight away, with the innovator ranibizumab group, for patients who had 0.75 logMAR units or better visual acuity, the improvement noted was 0.201 logMAR units of improvement, compared with the biosimilar ranibizumab molecule, which actually this group had 0.078 logMAR units of improvement. So you can see a substantial difference here between the two agents, and it was in favor of the innovator molecule. Moving on to eyes who had lesser vision, less than 0.75 or less than 636 on the Snellen's chart, the innovator ranibizumab group had 0.304 logMAR units of improvement, and the biosimilar group had 1.133 logMAR units of improvement. Again, this difference was statistically in favor of the innovator molecule. What about improvement of vision? Well, by 3 or more lines, 48% of the patients on the innovator group actually improved. And in the biosimilar group, it was 29%. This was considering a baseline vision of 624. If you look at the adherence of the patients to the same molecule, that is same anti-VEGF for more than 6 months, 23% of the patients actually stuck on to the innovator molecule as compared to 6.8% of the molecule of the patients on the biosimilar molecule. So there was a 3-fold difference that was noted here. If you look at the mean number of injections, it was 2.1 for the innovator molecule, and it was 1.56 for the biosimilar molecule. What about patients who took more than 3 injections? Well, it was 29% for the innovator group, and it was 16% for the biosimilar group. So in a nutshell, the evidence from randomized control trials do not fully match with real-world data, in the sense that improvement of visual acuity in the Indian context may be slightly more than what we have seen in the West, and drug cost may not be the only factor for compliance. Moving on to the DME part of the study, it was similar, non-randomized, retrospective, open-label, multi-center phase 4 study of 1623 eyes, the innovator group having 1159 eyes, and the biosimilar group having 464 eyes. These were all treatment-naive, center-involving DME. Both eyes could be included as separate cases, and of course, these had to be adults. And no switching was allowed here, and also any other retinal disease was not allowed. So moving on to the results, for patients with 0.75 or better logMAR unit or logMAR of visual acuity, the improvement here was 0.201 logMAR units for the innovator molecule, and for the biosimilar molecule, it was 0.137 logMAR units of improvement. If you look at patients who had lesser visual acuity, less than 0.75, here also the innovator group did better with 0.299 logMA units of improvement, and the biosimilar group had 0.191 logMA units of improvement. So in both these sets, actually there was a statistically significant difference in favor of the innovator molecule. Also in patients who improve one or more lines, 70% of the innovator group actually improved one or more lines compared to 53% of the patients on the biosimilar molecule. If you talk about adherence to treatment in diabetic macular edema, 13% continued with the innovator ranibizumab molecule beyond 6 months, whereas 6% actually continued with the biosimilar. So there was a twofold difference between the adherence of the two molecules. Regarding the mean number of injections, 1.63 for the innovator molecule, and it was 1.34 for the biosimilar molecule. Again, a statistically significant difference was noted in favor of the innovator drug. What about patients who received 3 or more injections for DME? 15% for the innovator, 7.7% for the biosimilar. So a twofold difference was observed here. Now, like all retrospective studies, our study also had its limitation. Visual acuity data was recorded in Snellens, and this was mostly a PRN-based regimen. However, one good thing was that the attrition rates were similar when compared with other real-world studies that have reported between 55 and 89% of attrition rates. However, when it comes to improvement of vision, we are not alone, because the luminous data has also shown that in treatment-naive patients, last 2 slides, sir. So the luminous data also showed that the treatment-naive patients tend to gain vision if treated, with ranibizumab. And of course, the Medicare claims data also shows that something that is relatively inexpensive, such as bevacizumab, had only a yearly, uptake of 3.1 to 4.6 injections. So we wondered why the better adherence. Was it because of the, safety and tolerability of the drug, or the proven track record? And so finally, in a nutshell, so visual acuity improvement was significantly found to be better with the innovator molecule, and real-world evidence for innovator ranibizumab actually showed that it was effective, as has been shown in the RCTs. And patients on innovator ranibizumab have 2 times significantly better adherence as compared to the biosimilar. Thank you for your kind attention.
Thank you, Dr. Chakravarti. Dr. Monrajan, sir, you had a question.
No, I wanted to ask Srinivas Rao, suppose you're going to put Vigad Dexa, the moxifloxacin, dexamethasone, for post-cataract patients. How do you take it off, or you just use it for 2 weeks and stop it off?
I use it for 2 weeks. And then initially I was very hesitant to stop prednisolone acetate and start this Vigad Dexa. They forced me, then I started, but the patient's complaints is very well, and I stop it on 14th day abruptly. And I continue with the Ilvera, the RN in FFNAC 0.3% for the next 30 or 45 days.
So you stop the steroids at the 14th
day, sir. 14th day, exactly, sir.
Okay. I use it for about 4 to 6 weeks, prednisolone acetate.
4 to 6 weeks, sir.
4 weeks at least.
4 weeks, yes, sir.
How about the other people here?
Well, I tend to use it for about 5 weeks, prednisolone acetate.
Prednisolone acetate, yes.
Yes, I also use it for about 6 weeks, 4 to 6 weeks minimum. And I think less than that, invariably patients develop redness, even if you're using epafenac. And I think steroids are probably necessary, especially combined surgeries. I even use it longer.
Absolutely.
Sir, only thing is, I substitute with the epafenac, sir, after a week.
See, the problem is nepafenac is good for cystoid macular edema, but as far as the inflammation is concerned, it is not so good. You can't compare nepafenac with steroids. So you need to have steroids, I think, in my opinion, at least for a few weeks. Otherwise, there's a possibility of rebound inflammation is coming. And it's really a troublesome problem, at least in my hands.
Correct. I sometimes find that even with prednisolone, the people come back with redness and pain with once a day, twice a day. And so we had to step up or go back to dexamethasone and so on. So I think, in my opinion also, I think steroids are definitely necessary.
I agree too, but it's anyway. Murli, I have a question for you.
Yeah.
So in your series, do you stop aspirin or clopidogrel before you do the Micropulse?
Aspirin, I have never stopped. Usually, even for any kind of intraocular procedure, I don't stop the aspirin. Only clopidogrel, I take the physician's opinion and stop the clopidogrel because you're getting a block anyway. You're getting a block anyway. So I think it's definitely useful to stop.
Das Ladegerät holen, nicht, dass es nachher gerade dann ausgeht.
Can you mute yourself, sir, please?
Das Ladegerät ist oben. Ja.
Can you just mute you?
Yeah, so I think definitely worthwhile stopping clopidogrel. Aspirin is not so important, I guess. And I always been stopping clopidogrel before any surgery which involves a block. And particularly for these surgeries in which you have neovascular glaucoma and so on, you don't want to take the risk of developing a high FEMA and other things.
What's the lowest IOP that you've had with this Micropulse?
I think definite 25-30% drop. In some patients have even had pressures coming down to 8 and 10 in the first month, and then slowly building up a little bit. So you can get even up to 30-40% drop in intraocular pressure. But no patient I have completely stopped medication. That's a fact. You will probably need at least 1 or 2 medication after the Micropulse also. You will not be able to completely take off the medication.
Thanks, Murli. And I think we have finished our 30 minutes. So we started about 20 minutes late. So I think we are more or less finished. I'd like to thank all the speakers and Novartis and organizers. Thank you.
Thank you. Thank you, Ronnie, and thank you, Dr. Mohan Rajan and other panelists.
Thank you very much. A wonderful session. Wonderful session. I came a little late, but it was very good.
You made it good, sir.
Rohit Om Prakash is there. Okay, we'll go on to the next symposium, which is by Hanita.
Sir, now 20 seconds advertisement, then we'll start.
Yes, yes, sir. Friends, we have the pleasure of introducing Lionel Raj. Okay, just like the new normal after Corona, it is the new person, new sensation. Lionel Raj, he is from Tirunelveli, down south in Tamil Nadu. He is attached to the Agarwal group of eye hospitals. And Lionel Raj is a great innovator, and he's going to moderate the session. Over to you, Lionel.
Thank you so much, sir. Thanks for the kind words. Shalom. Warm greetings to all of you. And we commence our industry-sponsored symposium, Hanita Lenses Symposium. I welcome, on behalf of IIRSI and Hanita Lenses, the eminent panelists of today's event, Dr. Johan de Lange from South Africa, Professor J.L. Alio from Spain, Professor Manfred Tetz from Germany, along with Dr. Devdas Mukhopadhyay and myself, Professor Lionel from India. So we start with the first speaker, Dr. Johan de Lange, an eminent ophthalmic surgeon of Eye and Laser Institute, Vanderbilt Park, South Africa. He would be talking to us on Hanita's breakthrough of all-range IOL, the intensity technology. Over to you, sir.
I think you should ask him to share his screen. Yes.
Yeah, I will be sharing the screen.
Thank you, sir.
There.
Right, I think you see it. Thank you very much. Everybody seeing the screen?
Yes, sir.
Thank you very much for the invitation to speak at this esteemed meeting, and also thanks to Hanita, who wanted me to share this information with you. This new lens is called the Hanita Intensity Lens, and it is vision redefined using dynamic light utilization technology. My financial disclosures. Then an overview of the lens. It's a new generation lens with maximal light intensity for clear vision throughout the whole range of functional vision. DLU, as mentioned, and then it's smooth and symmetrically distributed 5 foci with 12 different steps in diffractive edges. And then the pupil aperture optimization. Here we see the lens specifications. You have 2 different lens shapes. The one is a modified C-loop, and the other one is the bunny lens. The light utilization, DLU, design aspheric diffractive, and then the anterior surface spherical pupil aperture optimized. Refractive index, you see there, spherical aberration minus 0.13 micron. It's hydrophilic, acrylic, and the natural yellow-violet filter similar to what you have in your own lens. Here we see the square edge. Based on these pictures, Hanita intensity is perhaps the best square edge in the business. The lens profile, a diffractive profile. This is the center of the profile in front of the pupil. Here we go more peripherally, and this is in front or behind the peripheral pupil. It gives you a true focus response, which means you don't really have the so-called weak spots or flat spots in your vision between the different foci. And there are 5 different focal apexes. The one is for distance, one is for near, then intermediate at 80 centimeters, and then you have 2 intensifiers. And this makes a big difference in the through focus effect. Like all these lenses, they use the pupil aperture as an important factor to optimize the lens and the vision. This is for photopic vision up to 2.5 millimeter. For mesopic and scotopic vision, you get an overlap and it goes up to 4 millimeter pupil size. And when the pupil becomes larger, it is mostly for scotopic vision at night. The lens profile, once again, is developed in such a way that there's maximal light utilization. The pupil aperture makes a difference. And you can see here that the different sizes of the pupil utilize a different part of the lens. And this is photopic vision, which uses the central part of the lens. And mesopic and scotopic vision uses the peripheral part of the lens, all of that controlled by the pupil. Here you see the light distribution between different foci as the pupil dilates or constricts. Here the pupil is constricted about 2.5 millimeter in diameter, and here it goes up to 5 millimeter diameter at night. And that's the light distribution. What is interesting about this lens, there is maximal light distribution, utilization. It is better than all the other lenses on the market. You only lose 6.5% of usable light, which improves the quality of vision for the patient. Here, these lenses are compared to other lenses. The red lines there show us where the contrast sensitivity, the modulation transfer function is more than 50 lines per minute. And you can compare the intensity lens to the PanOptix, the fine vision, the 80 Lisa, and we have more red lines here, which means more quality of vision, functional vision for the patient. This is for a 4.5 millimeter pupil. And here, yeah, there was another one, but that doesn't matter. The fact of the matter is the intensity lens has more quality visual function than the others. Here we see the pinpoint spread function of the intensity. It's compared to the other best in the business, which is the PanOptix. We had a few of our own results. Unfortunately, we've only done 10 of these lenses, so our results are not yet statistically defendable and valuable, but it is still interesting to see the initial results. The contrast sensitivity that we tested on the fact charts of the intensities were a little bit better than the others, except for this one measurement, which was also good by the PanOptix. And then we have comparing mean uncorrected visual acuities of single eyes. If you look at the intensity here, it is in the group for distant vision. But when you look at intermediate vision, our intensity lenses gave a better average result than the rest of the group. And you see here are a lot of lenses. Unfortunately, all our pictures are in front of the other lenses, but it doesn't matter. It's actually perhaps a good thing. And then you see the intensity lens here on the right-hand side for near vision. It was better than any one of the other lenses in our group. And here we compared this picture now. Can we get rid of it? Can you see the intensity lens on the right-hand side. The intensity lens comparing mean vision for all distance for single eyes. Now you may ask me, what type of comparative value is this? The answer is it is what the patient actually experiences, because he uses both eyes open all the time for all distances. And if you look at the values of these average, or the averages of these values, the intensity was a little bit better than the others. It was 0.93, I think, 0.95. So it seems to be a very, very good lens. Here we have the subjective patient experience chart. I'm not going to go through it. And then just a short summary. The optical design is using DLU technology. It's a smooth lens profile, optical light distribution, best light utilization, continuous vision, and minimal side effects. And yes, this picture comes from Israel, where the intensity originates. And thank you very much for your attention.
Thank you very much, Professor DeLange. And some of these summarizing point for the benefit of everyone. So intensity with 12 different steps, differential heights, optimization, rather it is maximal utilization of light. Only 6.5% of light is lost, and the halometer showing better simulation than any other presbyopic lens counterparts. Better for near and intermediate than any other counterparts. Other than this, how is your experience with your patients, especially drivers, when you compare with other types of presbyopia correcting lenses?
Well, it's at least the same or better, but I've only done 10 of these lenses and I've only been doing it for 2 months. So it's difficult to give you a 1-year follow-up, say, but it's definitely excellent and definitely compared to the best of the others.
All right. How do you compare between EDOF and intensity in terms of your technology?
Yeah, it's a good question. EDOF is a long story, but I prefer to use trifocals, and the intensity is basically a pentafocal, and the other lens, Panoptic, is a quadrifocal. But in the end, the more focal points you have, the better your quality of vision is, and the intensity will give you better near vision than the EDOF lenses. So EDOF lens is great if you don't care too much about near vision and if you are prepared to wear glasses for reading.
All right. Thank you for all the information. And the discussion on intensity is not ending here, since the next presentation is about optical and visual performances. And towards the end of our session, you'll be demonstrating, showcasing one of your intensity IOL videos as well, the surgery as well. So it keeps going on, and we look forward from people like Dr. Mohan and Professor Tetz for their comments on intensity lens. Thank you, Dr. Johan, by this time. And now I take up this opportunity in introducing Professor J.L. Alio, cataract and refractive surgeon, head of Visum Institute in Miguel Hernandez University in Spain. He's known to everyone. He's known to everyone, and he's one of the principal investigators in almost all the IOL products, and is a board member of almost all major organizations. Personally, he's a great human being, and to me, he is a great mentor who encouraged me in several international forums. So let's listen to his lecture. He is unfortunately not joining us, but he has sent us a recorded presentation. Let's listen to his lecture on the quality of vision with intensity IOL. In the absence of Professor Alio for discussions, I request Dr. DeLange to take up the questions on intensity IOL, if any, and to lead the panel discussions on intensity. Thank you.
Hello, I'm going to show to you our experience with Hanita Premium IOL Intensity, which is a great innovation in our hands. And I'm going to show to you with my team, which have been our results, our outcomes, and which is our philosophy in the use of premium IOLs. My name is Jorge León. I am Professor and Chairman of Ophthalmology, University Miguel Hernández, and I'm the founder of Vision Institute of Ophthalmology de Alicante. I am consultant of Hanita lenses. I'm happy and proud to say this.
Stopped. Lionel?
Yes, it is.
First of all, what about premium presbyopic intraocular lenses? First of all, what about premium presbyopic intraocular lenses? Presbyopic correcting lenses is one of the main topics today because many patients are demanding to us not only spectacle independence for far, but also spectacle independence for computer use and for near vision. And our target is to satisfy these demands. Today, the trends in presbyopic lenses are multiple because we have multifocal lenses which can be diffractive and refractive. We have extended depth of field lenses that I will briefly address this topic now. We have Phakic multifocal intraocular lenses that are now appearing in the market. And finally, we have monofocal plus intraocular lenses that still are to be defined and still to know whether they work or not. Finally, the promise is to have in the future accommodative intraocular lenses that definitely will be an added value for cataract surgery, and they could be implanted intraocular or most probably sulcus place. But this is not the topic of this presentation. The topic of this presentation is what is about presbyopic lenses. And please read this article that there's an editorial that are recently published in Asia Pacific Journal of Ophthalmology, and definitely it covers very well which are the fake news that we have today in multifocal and premium lenses. We have many definitions that are unclear, we have outcomes that are not true, and we have a lack of adequate and sustained critical comment about what is the outcome, successful outcome, and indeed the choice that we shall have of the new intraocular lenses. So be aware that we have evidence, but we have masquerade news and fake news as well in the topic of presbyopic lenses. About the extended depth of field, the EDOF lenses, please be aware that according to the American Academy of Ophthalmology, which is the one that is supported the FDA mark for this type of lenses, these lenses are just for intermediate vision. EDOF lenses are not providing near vision, and so the patients implanted with these lenses will not be able to read without glasses. Also remember that whatever we do in the human eye, which is not accommodation, we are dividing the light and taking different types of focuses or different type of light manipulation. We all are degrading the quality of vision we use in these lenses, because if we increase the depth of field, the quality of retinal image is decreased. If we increase the aberrations to increase the depth of field, we are degrading the quality of vision as well. And so the balance about quality of vision, quality of retinal image, and patient satisfaction has to be remembered. Let me tell you now which is my definition of success. And my definition for success for multifocal lenses is that they have to provide my patients with good far vision. I don't sacrifice far vision for getting near vision. Second, they should be good for intermediate vision, which means to be 20/30 is enough, 0.7 decimal or 0.2 logmar, and about the same for near. So my privilege is for far vision, and then intermediate and near vision should be, to be successful, 20/30 and 20/25 respectively. All what I'm saying to you, and probably more, you can, if you are interested in reading this book about multifocal intraocular lenses, the art and the practice, in which the second edition appeared in last year, and you will find a lot of information, and definitely your criteria about how to use presbyopic lenses will be improved. Let me now make a point about optical quality and retinal quality. Both are related. The optical quality of the lens will be related and the design with the retinal quality of the image, and the retinal quality will influence a lot patient satisfaction. But remember, visual performance is not only retinal quality but also neuroprocessing, and the brain has to accept the new multifocal image that appears in the brain of the patient, and this will make the patient satisfaction to exist or not. Which are the most relevant factors involved in a successful multifocal lens neuroadaptation? Very relevant to understand our outcomes with the new Hanita intensity lens. Remember, you have to analyze the focus curve. You need to know which is the focus curve of your lens in order to know if this will satisfy your patient. But finally, contact sensitivity, it depends on the quality of retinal image. If the quality of retinal image is poor, contact sensitivity will be poor. And in multifocal lenses, you divide the light and it will be even poorer. So pay attention, please, to the focus curve and pay attention to contact sensitivity and the quality of retinal image that the lens is providing to your patient. Now I'm going to show to you our experience with this innovation, which is the Hanita intensity multifocal lens. We have been implanted these lenses now in the last 3 months, and we have a total of 10 lenses implanted. We have analyzed and we offer to you here the outcomes of the 3 months of follow-up in 5 eyes, 3 months, and we have used for IOL calculation in all cases the 118.6, and we have used the Paris universal formula. Remember, 118.6 and Paris universal formula corresponds to the outcomes that I'm going to show to you now. First patient is a female, 50 years old patient that was asking for refractive surgery. In this age, we usually offer refractive lensectomy. And this patient, as you see, was with a small hyperopia, small astigmatism, very good vision, and the patient was requesting to be spectacular independence for far and obviously for near, because that was the main demand. These were the postoperative outcomes after implanted the Hanita lens. Hanita intensity offer, as you see, an uncorrected for distance visual acuity in both eyes, 20/20, an uncorrected near vision acuity, uncorrected 0.8 both eyes, and as you see, the binocular vision was 1 and 0.8 respectively. We have plano outcome, and as you see, the patient was in a huge benefit of what was the result of the surgery. This is the focus curve that corresponds to this patient. You will see that the focus curves are not exactly the same in every patient, but you have to see here that we had excellent vision for far, excellent vision for intermediate and near, and we have a drop in intermediate vision in the right eye. This was about the right eye. But this is about the left eye. And this was the graphic. As you see, we have a peak in the far vision with intermediate vision and near vision with very good levels. Exactly, this is my definition of success. Very good vision for far and adequate vision for intermediate and near vision. Now let's see the focus curve of binocular. What matters to the patient is what is the outcome on binocular basis. And here you see that the binocular vision was with excellent vision for far, intermediate and near. And what I appreciate a lot is this plateau configuration flat of the curve, because it's very similar to what is physiological accommodation. Contact sensitivity was excellent. Look here that we were beyond the normal levels of the age. So with the lens, surprisingly, we got not only normal contact sensitivity, but a little bit more, probably because the patient was still in the 50s, and that was the standard was better than expected. But look how good is the contact sensitivity. This is about the left eye. Contact sensitivity function was excellent for all purposes, so we didn't degrade the contact sensitivity in this patient with the implantation on either eye and binocular. Here is the binocular image. As you see, again, we are over the standards in the graphic. In the graphic, you see which are the standards for the age of the patient in terms of contact sensitivity measured with the CSV 1000, and we are above the standards in far vision, in the standards in intermediate vision, and beyond the standards in near vision. Aberrometry shows to you the aspect of this lens. Please pay attention to this because this is new information. What you see here is the diffractive model of the Hanita intensity, and you see here the display of pyramidal aberrometry. In pyramidal aberrometry, we have cancelled the second order operation in the upper left, and look here what is the quality of the retinal image of this patient. And you see in the right and down what is the convoluted image of the Snellen chart and the ETDRS chart. As you can see here, the patient has excellent quality of retinal image, and as a consequence, the convoluted image of the chart, that is a simulation of how the patient is seen for far, is absolutely good. This is again the image, and look that the PSF of this patient is 1.69, which is really good. But Now the left eye. The left eye was showing even a better quality of retinal image. Look at the down left, how is the pinpoint quality, and about the convoluted image that is in the right, you can see how is that. Why these differences? Probably because the quality of the cornea. In a barometry, you see that you are studying the whole eye, and probably the patient had a higher level of corneal aberrations in the right eye that corresponds to the less good for intermediate, the focus curve that we saw in this eye, while this patient had a much better the focus curve because the quality of retinal image was better. Look at the convoluted image. Again, the convoluted image of this eye is 2.65, which is almost 1 point more than in the other eye, which reflects that the retina is doing very well with this lens, and probably this eye has a better cornea than the right. Halos are seldomly or never reported by these patients, only on request. As you see here, the halos of this patient measured by the halometer are minimal, and this patient was extremely satisfied. The patient didn't recognize any halos, and this is a binocular halometer. Now let me go to the second case. The second case was a female, 58 years old, with a right eye previously slightly amblyopic, and the patient was asking for refractive surgery. Again, at this age, we are basically performing refractive lensectomy. This was the vision of the patient, which was slightly more hyperop than the previous patient, plus 225, plus 1.5, with a near vision error of 2.5. We indicated to this patient refractive lensectomy as was within the indications of the surgery. But the outcomes, as you see, the patient accomplished 0.9 uncorrected distance visual with the right eye, 1 20/20 in the left eye, while uncorrected for distance for near visual acuity was 0.4 and 0.6. As you see in this patient, we had a binocular vision of 1.2 for far and 0.6 for near, very good, and we had an excellent outcome. And even for extremely near and extremely small print, the patient could be in the benefit of +1.
Can we shorten it?
This is the focus curve of the right eye.
Yes, sir.
You already.
Lionel, we are running short of time because we need to start the.
Yes, sir. But the control is with Kannan and the audio visual.
Kannan, yes.
Yes. So, yes, audio visual team can go for the summary, and we can collectively make a note.
Yeah.
All right. Anyway, yeah. Better that I speak. Thanks, Professor Alio and Dr. DeLange on this intensity. And whatever Dr. DeLange had spoken in terms of the technology is translated into the human science. Like there is a flat or a plateau-like binocular defocus function. That means for the entire range, distance, intermediate, and near, this lens is helpful. Improved contrast sensitivity of more than 1.7 log CS, and improved point spreads function, as well as reduced aberrations, higher order aberrations by aberrometry. These are highlights that differentiates this intensity lens from other types of presbyopia correcting IOLs. With this, now let's proceed to some of the landmark products of Hanita lenses. It's not alone intensity. Some of the landmark products are available with Hanita lenses. The first one to come now is the Perfection Outcome lens. This is quite interesting, and the perfect low cylinder solution for cataract patient. I introduced Professor Manfred Tetz from Germany, who has a vast experience of working in Europe and USA. He had been instrumental in establishing and developing several cataract and anterior segment establishments in his career, and is a board member of various organizations, scientific reviewer, and co-editor of numerous ophthalmic journals. I thank him for his presence today, and over to you, sir, for the perfect low cylinder solutions.
Hello, can you hear me? The voice is on. I have one request because the presentation was delivered to you. Is it possible that it's done from centrally? I basically commenting on my slides that you have on file, hopefully. Is that possible?
I think Lionel, you should ask Kannan whether it's possible.
Yeah.
Oh, here we are. That's it. Okay, thank you very much. If you just go into the presentation mode, and I may ask you then to forward. Thank you very much. All right. No, go back. One back. Here we are. First of all, good afternoon to everybody in Germany. Good evening in the part of the world that you are on, Mr. Chairman, dear audience. All the matters that we have heard before do only work if we really touch emmetropia. And emmetropia, usually with now modern formulas, can be predicted quite nicely in most of our patients. One of the little cumbersome things is the residual astigmatism. So for the last 3 years, we have been working hard to address low astigmatism correction for lens surgery. So in my opinion, astigmatism-free emmetropia is the ultimate goal to help us to implement all other optical improvement that we want to establish. Now, what is low astigmatism? This, okay, can you forward the slide? This is a diagram from a publication from Mr. Warren Hill, who looked at 6,000 preoperative cataract cases and looked at the preoperative corneal astigmatism in these eyes. And as you may see, 81% of all eyes undergoing cataract surgery do have astigmatisms that are less than 1.5 diopters. Usually, if you ask most refractive surgeons, they wouldn't want to use astigmatic toric lenses for correcting those. Most people do use the toric lenses for the higher astigmatisms. Why? Because there is a thinking in the community that it's so hard to correct, fully correct small astigmatisms. And we address this topic. Can we advance, please? So the goal was using a special lens, the Hanita perfector lens, which is a low cylinder IOL. And we implanted this lens through the 2.5 millimeter incision, but we improved our results on not using the standard calculators, online calculators recommendations by putting in a factor which is called surgically induced astigmatism. We developed together with a company here in Germany a smart calculator, and this smart calculator takes out the major influence of the incision-induced astigmatism, rather than using it, trying to take it out of the game. Now the IOL corrects 1 diopter of cylinder at the IOL plane, which is around 0.75 to 0.79 diopters at the spectacle plane. So it's a very, very small correction. We use this in the cataract eyes with expected good visual acuity and pre-op astigmatism of this 81% of populations between 0.5 to 1.5. Major other eye diseases were excluded. Can you forward one more? This is actually a picture of the printout of this eyesight vision smart calculator. And we put in this information of the pre-op astigmatism. And then, as you see with the green dots at the corneal limbus at 11 o'clock, the smart calculator recommends an incision that is most likely to not influence the post-op astigmatism. So now we have a different story. Pre-op astigmatism and post-op astigmatism will be very similar. Now, all of a sudden, the toric lens that we implant, the low toric lens, can now help us to reduce also small types of cylinders. If you put it on axis, you have a full 0.75 correction. If you put it a little bit off axis, a few degrees, you go down to 0.5 or even 0.25.
Last 15 seconds. Last 15 seconds, please.
Okay. This is the results. Next slide. And you see here that the post-op spherical equivalent was 0.001. The cylinder refraction was 0.44, And the interesting thing is that the standard deviation down at the lower was only 0.3. So in other words, see the blue circle and the green circle. The green circle is the post-op eyes that post-operatively, the blue dots all were within half a diopter of residual astigmatism, whereas before they were at 0.97. So we were able to reduce, next slide, sorry, forgot to, this is the circles. In the green circle, the blue points, less than 0.5 diopters astigmatism post-operatively. Last slide, please. So using the Hanita perfector and a special approach to reduce small astigmatism, we were able to turn post-operative cataract outcome into the results of post-operative laser refractive outcome, having less than 0.5 residual astigmatism, improving all optical results also for future multifocals. Thank you very much.
It's a wonderful presentation. I really appreciate your work. And I have one.
Can we have it at the end? We are short of time.
Final, we are running short of time, so we'll do the end.
Yeah. So thank you, Dr. Tex. And mine, I'll try to make it as simple as possible. Only 6 to 7% of the entire procedures are presbyopia correcting IOL. So we evaluated the optical performance and patient-reported visual outcomes of different premium hydrophobic acrylic IOLs, a pooled analysis of 2 different studies. One is comparison of optical and visual performance of different IOLs. One is patient expectations and self-reported outcomes in monofocal and multifocal for the Hanita group. So objective was to compare between different lenses available in the market. Sample was 119 with equal distribution. E2 SL-HP, C-lens HP of Hanita. These are other market available ones. So the sphere, residual sphere there was no significant difference in either groups. Cylinder.
Share the screen.
Oh, I'm sorry. All right. So, yeah, SL-HP is C-lens HP, equal distribution with other lenses also. So sphere and cylinder, there was no significant difference in either of the lenses. And one of the groups was multifocal lens, an apodized diffractive multifocal with +3 add. And this is an interesting slide. Multifocal, as expected, has the least contrast sensitivity. And interestingly, C-lens HP and Technis had the best contrast sensitivity among the group, all other available monofocal hydrophobic lenses. And similarly, the higher order aberrations was greater in multifocal as expected and least in C-lens HP and Technis group. So comparing both the slides, it is just inversely proportional. When contrast sensitivity was better, the aberrations was less. Both of them being independent variables. So this is what was our observation, and no PCO was noted. So it is glistenings, the material, all these are important. So what we found is harder the material, hydrophobic material, better was the outcome, visual outcome. That's what had happened with the C-lens HP and Technis group, and they had least aberrations, whereas better contrast sensitivity. That was what we found. So this prospective study concluded C-lens HP performed well in terms of residual refractive errors, contrast sensitivity, and had least HOAs. So regarding the patient expectations and reported outcomes, we similarly had subgroup of different monofocal lenses, and we had a multifocal lens, 32 lenses implanted in C-lens MF group. And it's interesting to note in monofocals, the near activities, they definitely needed glasses. The role difficulties were reversed after cataract surgery. Driving abilities was the highest. We used VFQ-25, which is a validated version of patient evaluation. In multifocal group, near activities was almost closer to 90%. There was spectacle independence, and reversal of roll difficulties was very good. However, driving, there was no significant improvement with driving, but still it was closer to 60%. So that is what between monofocal and multifocal. So to conclude, the premium C-lens hydrophobic lenses satisfied patients' expectations, enriched quality of vision, and reversed roll difficulties as like any other hydrophobic lenses. And multifocal lenses, C-lens MF, reduced spectacle dependency nearly by 89% in addition to quality distant vision and reversal of roll difficulties. However, needs a concern in drivers. Thank you for listening. And with this, I now take up the opportunity to invite and introduce the next speaker, Professor Devdas Mukherjee from West Bengal, BKJ Eye Institute. He has a wide experience in working with the NHS platform in the UK, and he renders service to the rural people in Eastern India. He'll be talking on efficient centration in the back with a 4-point fixation haptics. Over to you, Dr. Mukherjee.
Sir, I'm having your PPT actually. Shall I share?
Yes, please go ahead.
The slideshow, please.
Since he's taking time for slideshow, I have one quick suggestion or clarification from Dr. Ted's. Can you explain from your 18 cases in terms of rotational instability of toric IOL? Okay, please carry on, sir. Dr. Mukherjee, please carry on. Dr. Mukherjee, Dr. Devdas, are you muted? Kindly unmute yourself and proceed with your presentation.
You are muted by.
Please unmute, sir. Then I'll ask the host to unmute.
The host, can you please unmute him?
Yeah, yes, sir. 1 second. I'll just.
Yeah, please.
Can you listen to me now? No. Click here, dots. New dot. Sorry. I'm helpless. I'm sorry. Can you listen to me now at all?
Yes,
sir.
Yes, yes.
You can go ahead.
All right. So since then we have been implanted about 260 lenses so far, and till date is not bad. As a phaco surgeon, my expectation as a perfect IOL is that it must have predictable post outcome, possible to event through 2.2 millimeter of incision or less, quick unfolding, no handshaking excellent centration, long-term stability, and least fibrotic capsular bag reaction. I don't mind whether it is hydrophilic, hydrophilic. Present, we are using two 4-point design haptic lenses. One is our Bunny and other one from the other company. So comparison between the Bunny AF lenses and the equivalent 4-point, overall diameter in Bunny is what I get actually 11.0, but the other lens has got the different overall diameter. Optic diameter is fixed, is 6 millimeter in Bunny lens, but the other lens have the 6.2, 6 or 5.6. Haptic angulation is 5 degree with Bunny, the other lens have the 10 degree. But one thing I love with the Bunny lens, that it has got the Bunny ears, which is compressible. That means it can accommodate a little bit of wider range of capsular bag diameter. Now, what I find about the handling of the Bunny lens is that during implantation, regarding handling, folding, haptic capture in the cartridge, implantation, unfolding, centration, tilt, no need of surgical special cartridge for 2.2. All these parameters for the Bunny lens was excellent. That's one point I was queried in me is that the overall diameter of the capsular bag by to-height distance affect the post-operative refractive outcome for those with 4-point fixation lenses, because the resilience of the haptics are much less in comparison to the open C-loop design. Probably white-to-white measurement is indirect measurement of the capsular bag diameter. If so, overall length of IOL will determine exactness of the fitting of the lens in the capsular bag. Thus, will determine the effective lens power. If it is tightly packed, the optics will go slightly back, and loosely it will come forward. And I think these are the queries I have. It is not been cleared at all, so I'm not going through this. So I've compared with few open C-loop lenses without Bunny lenses. Now we have 259 cases. White to height was available in 215. In the most case, we have got the white to height diameter is 10.5 to 11.4. But if you go up to 12 millimeter, it will be something 63%. In comparison to Acrisop lens platform, which has got overall diameter of 30 millimeter, but with Bunny it is 11.0 to 11.5. Open C-loop has got much compressible element in the haptic design, but with the Bunny lens, there is some amount of compressibility in the haptics. So, and it has got a 5-degree angulation with a very tightly snug fit capsular bag. That optic will slightly go back and might affect a little bit of effective lens power. There are a few studies fixation. They all found that the 4-point fixation has got the more rotational stabilities than the other open loop lenses. There are different, parameters. They did score study in a hospital again for
Doctor, can you please summarize? Yeah, please.
Yeah, can you listen to me? I'm summarizing. So we have found that refractive outcome is within 0.5 is 57, 1.72%. So achievement of the refractive error is quite high with Bunny lens. I am and my patients are satisfied. And I'm not positive, negative. This is equally balanced. This is the area, the gray area in the target refractive error is well 70% for patients. post-operative outcome is excellent. Rotational stability is very fine. And in these parameters, these lenses are super in opinion. And here, thank you.
The winner in this other specialty category is Dr. Ritika Sen, and her video entitled.
Can you please summarize, Doctor? Because we have got video showcasing of.
It is. I don't know. I have finished.
And let's have a look at her winning video in the other specialty category.
I can listen anything else, something else.
That's okay.
I finished.
Yeah, please. You have finished. Okay, very good.
Yeah.
So thank you so much.
Listen something else.
Okay, that's okay. Thank you so much for your wonderful presentation. Without losing time, I hand it over to Dr. D. Lange for his showcasing of his surgery on intensity.
Dan gaan die video wys loop. Ek het nie die video op skerm nie. Moet ek sê wel, hulle moet eers daai ding wegvat.
Doctor? Doctor Devdas, you need to stop your screen share for the next person to share.
Is okay now?
Professor Johan, please go ahead.
We are here, but I don't see the video. We have it on a memory stick here where we can start playing it from our side.
Okay.
All right, so sit a moment.
Okay, sir.
Well, okay, do you see it?
Yes, we see.
Okay, good. That is a standard cataract operation. I use not the bimanual technique, a normal temporal incision. The temporal incision I prefer is a 2.5. I make a vertical incision first and then the oblique incision into the stroma, going into the anterior chamber. That ring you see there is the Callisto pupil size. It is 5 to 5.5 millimeter size. We adjusted at 5 to 5.5 because there is a small variation possible. This is viscoelastic going in. Well, that was adrenaline. And now that's the viscoelastic, the OBD going into the eye. And we will now show ourselves the Callisto capsular rhexis ring again. And starting now with the CCC. The left-hand instrument is local homemade bent cannula, which we've been using for many years, and I'm used to it, so I don't find any reason to change it. Now, this is the CCC trying to stay equal to the size of the Callisto ring. As you can see, the eye moves, so it's not possible to keep the Callisto ring 100% still and quiet in front of the cornea. But after doing in the CCC, we'll see that it's quite accurate in size. It's about 5 millimeter in diameter. So that's the CCC done, and if you compare it to the Callisto ring, it is fine. Then it is followed by hydrodissection, trying to do hydrodissection and hydrodelineation. You saw the second fluid wave going through. And now I do the pre-chop technique of Akahoshi. I've been doing it for many years. I find it very comfortable and very safe. Rotate the lens, do the second part of the pre-chopping. And then we have 4 quadrants to remove. So everything seems to be going smoothly, no problem. And now we're going to start the phaco. I use the infinity phaco, and if the patient is younger than 70 years age, I use the 3rd level of phaco power. Starting to remove the quadrants, 1st quadrant, 2nd quadrant. This is live surgery. We did not edit it, so this is about how long it takes on a slow day. But so it is going well. The quadrants of the nucleus are basically out. And now I will do the cortex removal with the aspiration irrigation cannula. The time between moves is for the sister to change the instruments. We're just removing some mucus from the eye. And we will now start doing the cortex removal. Here is the aspirating irrigation cannula going into the eye, removing the cortex. This is an easy, smooth cataract, no problem, no real challenges. Just have to be safe and accurate, and then we should be fine. You can all do this. You've all seen this a million times, but it is still a little bit of a challenge to protect the posterior capsule. It has to be done every time. And here we get rid of all the cortex. There is still some viscoelastic visible inferior close to the cannula. And I remove a bit more of the cortical material, aspirating it. Now the lens is not pre-folded. The lens we have to fold it ourselves, put it in the injector. Here we do some visco dissection of the remainder of the cortical strands on the posterior capsule, trying to get it 100% thin and smooth and clear. And that being done, we are now going to insert the lens. The injector does not have a bevel tip, which I do not particularly like. I want them to make a bevel tip, but it's not difficult to get it through this incision. Some people use a smaller incision, which is fine. That is their decision to make. As far as post-operative astigmatism is concerned, this incision gives me about a 0.25. Here we see the lens gradually going into the bag, unfolding slowly. As you can see, there's nothing dramatic about the lens unfolding. It happens slowly, it is safe, it's easy. And what we do now is we just position it carefully, making sure that the haptics are in the bag. There we have the other haptic on the opposite side. Now I reposition the lens a few times to try and make sure it's 100% central, because decentration of the lens more than 0.4 millimeters can cause loss of visual acuity and visual performance. The lens is neatly in the bag, still moving it a bit up and down. You can see a few bubbles there. So what we're going to do now is to remove the viscoelastic first from behind the lens, the OBD. We aspirate it from behind the lens from the back. So we want the lens to be against the posterior capsule every time, because if the lens is displaced forward, you create myopia. So this lens is now in the bag against the posterior surface of the bag, and we remove the viscoelastic, the OBD, from the anterior chamber. As you can see, the lens still moves a bit, but that is not a problem. We'll center it in a few moments. And here we make sure all the OBD is out of the eye, and we are close to the end of the surgery. Everybody's happy. You can see the rings of the lens, as been explained in the previous lecture. And now I hydrate the wound, which I always do, perhaps a bit too much, but that's a personal preference. I'd rather do too much now than bring the patient back the next day. And then we inject Vegamox into the anterior chamber to make sure to reduce the chances of post-operative infection. And there we have the Hanita intensity lens in the eye, and we expect a good result the following day. And thank you very much for your attention, and I hope the patient will be happy, and I really expect to see a good result. Thank you very much.
That was a wonderful surgical demonstration, a perfect rhexis with perfect centration of presbyopia correcting lens. So that was excellent. So thank you one and all, and it's a great session with intensity technology, the patient outcomes, and it is so great to hear about the perfector. I really enjoyed your presentation, Dr. Tates, and also that Hanita has got a good range of lenses of hydrophobic and 4-point fixation lenses. So we have come to the end of this Hanita symposium. I thank the office bearers of IIRSI, and a special thanks to all the panelists who took time to invest yourself in this particular evening program. And looking forward to further developments from Hanita lenses and a straight face-to-face seeing congresses in the future days to come. Thank you all. Thank you so much.
Thank you very much.